Okay. मैं बंद कर देगा। हाँ सर।
Support team, kindly mute everyone first.
Can we begin supporting?
Yeah.
Okay. So, Namaskar and good evening, everyone. A very warm welcome for today's webinar on clinical updates in the management of NSCLC. And for this, I would like to invite Dr. Rajesh Bolam, who is consultant oncologist and hematologist at Yashoda Hospital, Sikandrabad, Hyderabad, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Today, in the next 1 to 2 hours, we'll be discussing on latest update in NSCLC, metastatic NSCLC. And the first talk for today is comprehensive genomic profiling in NSCLC, what, why, and when. To speak on this topic, we have Dr. G. Arun Kumar, therapy area expert, personalized healthcare from Roche. Welcome, Dr. Arun. Please go ahead with your talk.
Thank you, Dr. Rajesh. I'll share my screen now. I hope my screen is visible.
Yes, Arun, it is visible.
Thank you. Thank you, and a very good evening to one and all. So I'm Arun Kumar. I'm basically a geneticist, and I work as therapy area expert for the personalized healthcare division of Roche, India. Today, I will share some thoughts about what is comprehensive genomic profiling and how it paves way for personalized treatment, particularly in lung cancer. So these are my standard set of disclaimers, and this is the agenda for today. Where I'll start a bit on the basics of cancer, then introduce the concept of CGP, then we'll try to address the questions of what, when, and why to use it in non-small cell lung cancer. So cancer, to understand the basics of the cancer, this might be a bit redundant, but overall, the genomic organization really dictates the way in which the cancer happens. So we have the most basic form of the genome, which is the DNA, which is wound around certain particles, proteins called as histones to form the nucleosome. And that is further compacted as 300 and 700 nanometers particle. And the most condensed form of the genome is the chromosome, the classical X-shaped structure that you see. But this classical chromosomal structure happens only during cell division, whereas in an interphase cell, that is a regular living cell, it is somewhere around in this conformation, and wherever gene expression has to happen, the unwinding takes place. Now, genetic aberrations at any of these genomic organizational levels, be it at a DNA level, gene level, 700 nanometer particle level, or at a chromosomal level, it can lead to malignancy. So what causes those changes? Of course, things like carcinogens, radiations, viruses can affect these can cause these genetic aberrations leading to cancer. Now, how does that translate into a malignancy inside the cell is that the DNA, whenever, as we know, the central dogma is DNA synthesizes RNA or codes for RNA, and RNA codes for proteins, and the proteins come together to form certain pathways, molecular pathways. So you have the RAS-RAF pathway, you have the PIK3 pathway, etc. Now, what happens in a cancer tissue is that when the DNA is altered, it affects the RNA and the protein, which end of the day again causes disruption of the molecular pathways. Now, the point here is understanding the DNA mutation really helps us to understand which of the molecular pathways are altered so that we can have our treatment strategies accordingly. So the concept here is cancer is essentially a disorder of the genome, and understanding that genetic disorder requires us to understand the DNA so that we can understand the pathways and we can form therapeutic strategies. So there are four major causes, mutations that are well known. One types of mutations. One is the most common base substitution, where one DNA base pair becomes another. In this case, a A has become a C. That leads to a single amino acid change in the protein. Then you have the insertions and deletions, where one or two nucleotides can get inserted or deleted in a sequence. Best examples is our EGFR exon 19 deletions. Then you have gene amplifications, like or copy number variants, as we say, like HER2 amplification, amplification, etc. And you have translocations, where the process of rearrangement takes place. Say one gene gets cut from a region and gets pasted in another region, close proximity to another gene, forming a chimera protein. Best examples are ALK fusions, EML, ALK4. Now, the point is the technology that you use to identify the genetic aberration needs to pick up all these four classes of genetic alterations with very high precision. So that technology is the NGS technology, which has really revolutionized the way in which we approach a diagnostic conundrum, and it's highly massively parallel sequencing. So any sample is basically extracted DNA, you chop them into 150 base fragments, and you capture the regions of interest. Say I'm interested to sequence 7 or 8 or say 100 or 200 genes. I design probes to those genes and I make them hybridize and wash off the remaining. So we pull down the genes of interest, then we do what is called as ligator adaptation, and we do the sequencing. Now, the most challenging aspect of this process is the bioinformatic analysis. Just to give you an idea, every sequencing run produces close to 5 gigabytes of data, and that needs to be analyzed to make clinical sense out of this. So just like how to interpret tissue, you require a pathological expertise. To interpret the genetic data, you require a good bioinformatic and clinical genomic expertise. So what exactly is this CGP? So essentially, I have established that NGS is a technology which can sequence large fragments of the genome. Now, these are different genomic technologies, and on the top you see the numbers, which are essentially our nucleotides, or if you go back to the first slide of genomic organization, 1 being at a DNA level and 10 to the power of 9 being at a chromosomal level. Now, PCR techniques and Sanger sequencing can pick up genetic aberrations of around 1,000 bases in size, up to 1,000 bases in size. MLPA somewhere from 100 to 1,000 bases up to 10 to the power of 7 bases. Whereas all your karyotyping fish and cytogenetic techniques are useful to pick up genetic aberrations at a higher order of the genomic organization. But theoretically, next generation sequencing is the one that can pick up genetic aberrations across the entire spectrum of genomic organization. So the sequencing technologies and the way in which we use various laboratory techniques have also evolved over time, starting from immunohistochemistries, FISH and PCR. Then we had the Sanger sequencing, which is the first generation sequencing. Then you had hotspot based next generation sequencing panel, about which I'll just touch about in a next slide. And we have the comprehensive genomic profiling, and last we have the whole exome and the whole genome sequencing, which are typically used at the research end. Now, when you have genetic aberrations to be picked up, you can use FISH or PCR or genomic sequencing. When you want to look at aberrations at RNA level, you do RT-PCR or RNA sequencing. And when you want to look at the expression of protein, you do the immunohistochemistry. Now, of all these techniques, we should understand which is more comprehensive in nature. So things like immunohistochemistries, PCRs, and FISH are very specific to one particular mutation. So they pick up genetic aberration in a gene only at say 1 out of 5 different mutations, because they're very specific. So if I have a PCR for BRAF V600E, that picks up just BRAF V600E and no other mutation in the BRAF gene. Now, category 2 types of assays are those like hotspot assays, where few of the mutations are picked up, but not all, because the assay is designed to do that alone. For example, you have hotspot NGS, where you have 1 or 2 exons being sequenced and not the entirety of the gene. And currently, these hotspot NGS panels are all getting weaned away, and people are moving towards comprehensive genomic profiling, where the entirety of a gene is sequenced so that there is no stone left unturned. Apart from this, a comprehensive genomic profiling will also give you information on genome-wide markers such as, MSIs and tumor mutation burden, along with, in specific cases of ovarian cancer, you can also get LOH score or the HRD score is also possible. So essentially, to summarize, the CGP is a technology which is NGS based, which sequences the entirety of the gene and large sets of genes, and it also gives you information on TMB, MSI, and LOH in a particular tumor sample. Now comes a question: when to use CGP? So the recent ASCO guidelines, which states that patients with metastatic or advanced cancers should undergo genomic sequence, and multi-gene panel-based assays should be used if more than one biomarker-linked therapy is approved for the patient's disease. So what does that mean? If there is more than one targetable mutation in the type of tumor, it is recommended to go for comprehensive genomic profiling. So in case of lung cancer, of course, we know that the targetable mutations are much more than any other solid tumors put together. So it is recommended to do CGP upfront for a lung cancer. Now, the clinical benefits of CGP include diagnostic value. For example, Ewing sarcomas is diagnosed only when you do identify a EWSR1 fusion. Likewise, the type of lung cancer, molecular type of lung cancer, whether it's EGFR mutated or if it is ALK fusion positive, it's done only by NGS. Then you have prognostic value, how severe the cancer is affecting based on the type of mutations. Then you have the therapeutic value. Of course, this is one of the major reasons why we end up doing the sequencing. Then you have the predictive value, where there are certain biomarkers that can predict the outcome of the disease, that can also predict the response to certain therapies. For example, ARIDA1A predicts a response to immunotherapy. You have PDL1 that predicts response to immunotherapy. TMB is also a predictive marker for immunotherapy. So CGP helps you identify all these four aspects, which can help in a clinical, which can have a profound clinical benefit. Apart from that, the most important thing is CGP is a key tool to understand the biology of the tumor. Now, why to use CGP? Let us try to see if there are evidences that show the utility of CGP. So over the years, we know our molecular understanding of, say, in this particular case, the lung cancer has improved tremendously. What was just KRAS and EGFR mutated lung cancers in 2004? In 2014, we had a whole range of other mutations such as ALK, HER2, BRAF coming up. And in 2017, we have a lot more new genes that have been identified. And within the EGFR itself, you now had sensitizing mutations, you had resistance mutations being identified, such as T790M, and so on and so forth. So how do you identify all these, which are clinically actionable, is using CGP. So why it has direct effect on the therapy, I don't need to go in details of this, because we all know the list of drugs available for alterations such as EGFR, ALK, BRAF, KRAS, HER2, MET, everything. So those colored in orange are those that are under investigation, and those colored in dark blue are all approved therapies. So these are the list of therapies that are available. So essentially, to identify these list of therapies, one has to, identify the mutation in the first place with high precision. So there are certain studies which have shown the advantage of doing a CGP over standard of care tests. For example, in one study, they took 86 patients who were previously EGFR and or ALK tested using standard molecular testing, which includes your immunohistochemistry or PCRs. Then EGFR, 81 tested were negative and 5 were inconclusive. ALK, 71 tested negative and 1 was inconclusive. And of these, when the same 86 patients were subjected to a hybrid capture, that is NGS-based comprehensive genomic profiling, 15 patients were found to harbor genomic alterations in EGFR or ALK despite previous negative reports, which is a substantial amount of false negativity in your conventional test. 80% of patients underwent targeted therapy using the EGFR or the ALK inhibitor respectively, and there was a 67% response to the therapy. Hence, a broad CGP-based approach really helps you not miss any mutations. And likewise, if you take the example of ALK in another study of 1,070 patients, 47 had ALK rearrangements. Of these, 31 had previous FISH results. 35% of the cases that were tested were negative when they were tested by FISH. So there was a good amount of false negativity that comes up when you do a FISH-based ALK estimation. And 78% of those treated patients had a confirmed response, which is a significant number. Now, if the FISH was alone taken as the last word, and the patient would have been on classical chemotherapy, which response could have been not all that great. So in summary, the standard molecular tests such as immunohistochemistry, FISH, or PCR complement for the CGP. So we are not going to trying to say that these tests are not required, but they really complement CGP. Now, the utility of doing CGP upfront is that it detects several markers at once, avoids tissue exhaustion, which is a very practical issue we face daily, and of course, it saves time. You get maybe in a 2.5 weeks time, the entire genetic makeup of the patient's tumor, which has profound effect on the clinical utility. So the next key message I would like to discuss here is how comprehensive genomic profiling drives precision medicine, which is what the world is moving towards in the future. So we started the treatment of oncology with one drug fits all approach. Then we had biomarker based therapy. For example, classical example is your PD-L1 testing, where based on a single biomarker, you give a drug and that drug has an effect. So you give a immune checkpoint inhibitor based on it. Now, again, I'm sure in your clinical experience, you would have seen patients, even if they were PD-L1 positive, some of them, a subset of them might not have responded, as well as another subset of patients. So now the world is moving towards one patient, one tumor profile, more options. So that's where the precision medicine is moving. So how is that happening? As famously said by Dr. Vivek Subbaiah, if you're serious about treating cancer, you need all the information available, and genomic data is an integral part of that information. So there was this very interesting paper very recently, I think in the August of this year, where the cancer pathways were taken as were analogous to the nine-headed hydra, which is kind of a Greek mythical creature. And if you slay one head, another head grows. So if you block EGFR pathway, PIK3 pathway comes in. If you block the PIK3 pathway, maybe a third cell cycle inhibitor pathway comes in. So ideally, to slay this hydra, one has to see what are all the various pathways activated upfront in the patient's tumor, so that you can develop appropriate strategies. So which is what they call as N-of-1 combination therapy, where depending on the major pathways that are affected, you give a combination therapy. So how is that mediated? The molecular tumor boards are the key for its success, which typically includes, apart from how does a molecular tumor board differ from a regular tumor board is, apart from the various clinical oncology divisions like surgical, radiation, medical, etc., you have organ specialties, pathology, but you have the molecular biology as well as clinical geneticists also involved, which really helps you to look into the molecular aspect of the report, pathway analysis of the report, which facilitates further interpretation of the molecular data and give very targeted assigned therapies based on solid science backup. So how is its effect? So this was a study conducted in University of Kentucky, where they just classified two groups of patients, one all non-small cell lung cancer, one treated based on a molecular tumor board recommendation, the other regular, without a molecular tumor board, the treatment as a standard of care was given, and you can see the excellent difference between those treated with molecular tumor board. Their survival probability was much higher compared to those who were not treated based on the molecular tumor board recommendation. So, of course, there are certain challenges in the study, which I do agree, the numbers, etc. But this gives you an idea of how effective a targeted therapy, personalized therapy, which is based on a multi-dimensional, multi-functional molecular tumor board happens. So lastly, I will summarize with a couple of interesting case studies. So this first case is a case of a 56-year-old female who had a right upper lung nodule, and lobectomy was done. And pathology showed it was a non-small cell lung cancer. There was not much of distant metastasis. Now, at the level of testing, diagnostic testing, they did a RT-PCR for EGFR. FISH for ALK was performed, and an amplicon-based hotspot NGS panel was done. Now, and PDL1 was also done. Now, the RT-PCR showed EGFR mutation in exon 18, G719X, whereas the hotspot testing revealed a very high tumor mutation burden, and the EGFR mutation was not identified. Now, this is a real conundrum. Which do you test? If you rely on the PCR report, you go to give a EGFR TKI. Whereas if you rely on the NGS report, you start immunotherapy because PDL1 was, TMB was very high. And these two are two extremes. EGFR mutated or driven cancers don't respond to immunotherapy. So here is where the doctor, again, because of this confusion, did a CGP. And in fact, it identified 3 EGFR mutations, all in exon 18. So essentially, the one that was picked up in the RT-PCR was one of the 3 EGFR exon 18 mutations, which is G719S. And the tumor mutation burden was intermediate. So the lesson here is that when you have a hotspot testing, you end up covering small amount of the genome and not exhaustively. So the calculation of TMB is terribly affected when you do a TMB estimation based on a smaller panel. And because it's a hotspot, it missed certain rarer mutations which are seen in the EGFR gene. And this EGFR exon 8 in this particular mutation responds very well to any of the TKIs that you give for first line for any of the EGFR-driven cancers. So the patient was treated on afatinib, and the patient responded very well. Now, this is a case of liquid biopsy where a 66-year-old female former smoker progressed on cetuximab plus afatinib. She had at diagnosis a EGFR mutation. Now, after a year, she progressed, and a liquid biopsy was done where a interesting FGFR2 fusion was identified. Now, this is not a typical gene that you identify or a fusion you identify in regular tests such as hotspot. And when you deep dive and a molecular tumor board was done, we found that there are evidences to show that FGFR2 fusion is one of the resistance mechanisms for TKI therapy against EGFR gene. And now you do have FGFR inhibitors coming up. This was, I think, a year or 2 ago. Now you do have FGFR inhibitors coming up. Then, the point here is CGP can identify such infrequent and unanticipated mechanisms of resistance, some of which can be targeted. And this is quite a recent case that we came across, a 52-year-old female diagnosed with stage 4 lung adenocarcinoma. A biopsy was non-small cell lung cancer. Tumor was not resectable. So EGFR by RT-PCR was done using the coupons. It was negative. ALK and ROS by IHC were negative, but PDL1 on IHC was very high. PDL1 was positive. So as because it's PDL1 positive, as a first line immune checkpoint inhibitor with a platinum was given. But immediately within 2 rounds of therapy, patient showed very heavy progression of the disease, and after which the Foundation 1 CGP, comprehensive genomic profiling, was done. And we interestingly identified MET exon 14 skipping mutation. So this tumor is driven by MET exon 14 skipping, which was missed in the initial testing, which is typically done in an Indian scenario. So we know the MET exon 14 skipping is a classical mutation which can be treated with capmatinib or crizotinib. And the patient was given capmatinib monotherapy, and and the clinician said the patient has clinically improved within a cycle or two, and the disease regressed after 2 lines of TKI therapy. So I hope this short talk really helped you to have a glimpse of what comprehensive genomic profiling is and how precision medicine can be practiced using this tool of comprehensive genomic profiling. With this, I thank you all for this opportunity, and I'll be very happy to answer any questions. Thank you.
Thank you, Dr. Arun, for your talk on comprehensive genomic profiling in NLC. Why, what, and when. If any of the panelists do have any quick questions, they can ask, or if anyone in the audience can ask their questions in the chat box. Ankit, if any questions are there, we would be happy to. Just we'll direct it to Arun.
Sure, sir. No issue, sir.
Yeah.
Dr.
Speaker has one question. Hybrid capture versus amplicon-based NGS.
Sure. So I'll answer that. I in fact have a big slide on it, but I didn't add it here in the interest of time. So amplicon-based NGS, what happens is although its sensitivity is a tad higher compared to hybrid capture, amplicon-based NGS has a problem that you artificially increase the number of templates, which essentially means your variant allele fraction detection is limited and the complete coverage of the gene doesn't happen. So most of the hotspot NGS are amplicon-based. So for example, in EGFR again, many of the amplicons don't cover the entirety of exon 18. They start from the second half of exon 18, then exon 19, 20, and 21 are covered. So amplicon-based NGS has this issue where it is hotspot in nature and it doesn't cover the entirety of the gene. Whereas hybrid capture really helps you to overcome that issue. And second, another important thing is amplicon-based has a lot of PCR duplicates. That is, suppose I have, say for example, 50 templates, 50 DNA fragments. When I do a hybrid capture, I actually sequence those 50. Whereas when I do an amplicon, I sequence 25 of those 50 by amplifying that to 100. I just select 25 of those 50 templates and I amplify to 100 and sequence that 100. So that becomes, that has the potential to miss certain mutations that could be there in the gene. So amplicon was great when NGS started maybe 10 years ago or maybe even until 5 years ago. But with the advent of hybrid capture, that is the gold standard currently. I hope that answered your question, Dr. Shikhar.
Yes, sir. Thank you for that.
If there are no further questions, then next we would be proceeding to the next session. The next talk would be by Dr. K.V. Krishnamani sir, consultant medical oncologist in American Oncology Institute, Hyderabad. Sir would be speaking on role of atezolizumab, Tecentriq, in first-line lung cancer. Welcome, sir. Sir, you are mute, sir. You are on mute.
Good evening. Am I visible and am I audible?
Yes, sir.
Yeah. Thank you, Dr. Rajesh. Thank you, everyone and organizers for this opportunity. I think my slides are online, so we can directly go to the talk. Can my slides be relayed? So till they take that time. So this talk is basically on the role of immunotherapy, specifically atezolizumab. And as Dr. Arun has already pointed out, we have moved a lot in lung cancer, the metastatic lung cancer precisely. We have moved away from the days of small versus non-small cell or adeno versus squamous. Those days are gone. The days of chemotherapy are slowly fading away. in a large population, especially the driver mutation, and then PDL1 comes into the picture, and then you are also starting to look at rarer mutations with NGS and in second line and third line. So a lot of discussion will center around EGFR, ALK, etc. But my topic, I would stick to it, is first line non-small cell lung cancer, and specifically one of the immunotherapy molecules, that is atezolizumab. Next slide. Next slide. So this is my contents for today. A brief history of the non-small cell lung cancer group, and then how the cancer treatment in lung cancer has evolved over the last few years or decades. And then the three main pivotal studies, which is 110, 150, 130 for atezolizumab, and we'll briefly summarize the data. Next slide, please. So just rush through this slide. Non-small cell lung cancer is the majority, 80 to 85% of all the lung cancer. 15% of patients are never smokers, but I think we increasingly see a large number of never smokers women in our clinic nowadays who come with adenocarcinomas. The number is increasing. The precise reasons are not known. The age of 70 years, presenting with cough, chest pain, dyspnea, hemoptysis, breathlessness, etc. But we see a lot younger too, 30s, 40s, 50s now. Most patients present with stage 3B or stage 4. They present with pleural effusion or disease at distant sites. And point number 6 is targeted agents have improved survival. So when you're looking at a woman or a man, non-smoker, adenocarcinoma, so the mind immediately starts functioning that you're going to look for driver mutations. And if you're going to have driver mutations, you have potential targets. Next slide, please. So the landscape of lung cancer treatment has evolved. So when we started off reading our pathology in the late 90s or the early 2000s, it was more about small cell versus non-small cell. And then the pathologist used to tell you in non-small cell whether it is adeno versus squamous. And then the chemotherapy came into being, and you're talking about paclitaxel carboplatin. And then we looked at histology-specific chemotherapy in the form of pemetrexed, which was given for non-squamous non-small cell lung cancer, bevacizumab used for non-squamous non-small cell lung cancer. And then the driver mutations were detected, especially in the patients who were never smokers. We looked at EGFR, ALK, ROS, and then a host of new mutations like RET, MET, HER2, etc. now evolving because of the NGS. And then PDL1. And PDL1 has completely shifted the goalpost, and now we are talking about immunotherapy. Immunotherapy started in second line and then now coming to first line. And in first line, you not only have pembrolizumab, you have atezolizumab and a host of other immunotherapies. So we have come a long way, and this is changing every day, and we have to update constantly. Next slide, please. So despite all this advancement, despite the fact that we have EGFR, ALK, and driver mutation patients who are surviving now for a median survival of 3 to 5 or sometimes even 6 years, there is an unmet need. So overall survival, if you look at the graph, the way it is stratified, those patients who receive targeted therapy versus those who receive non-targeted cytotoxic therapy, the overall survival is much more. Very, very easy to understand. In our clinic, we see a lot of patients. Chemotherapy is given for a finite number of cycles, impact on quality of life, neuropathy, cardiotoxicity, etc. And you have to stop at a particular point and the disease comes back later. Targeted therapies, now if you look at the EGFR agents, you look at erlotinib or geftinib, the PFS was close to around 12 months, 9 to 12 months. So similarly, is even much higher in the first line. ALK agents similarly. So all your targeted agents lead to better overall survival, better quality of life. You use it till progression or toxicity. But you look at the other part of the circle there, or the pie chart, there you see KRAS mutations and unknown mutations, 35 plus 30, 65% of the patients, you still want to do something, but you're unable to do something. In 35%, we are not yet there to find out a mutation, or we find a mutation, we don't have a target. And the mutations for which we are actually able to do something is hardly EGFR 10%, ALK 5%, ROS, HER2, etc. So there is an unmet need for us to look for biomarkers. Next slide. So this is where PDL1 came into the picture, and we started looking at other biomarkers like PDL1 and advanced NGS. So I would stick to atezolizumab, which is immunotherapy. And what are the 3 pivotal studies? 110, 130, 150. Let us go in that one order. 110 is basically atezo versus chemotherapy. Let us keep it very simple. So squamous was there in that, non-squamous were involved, around 500 odd patients or 600 odd patients. The the trial was to see if atezolizumab monotherapy, how does it compare to your chemotherapy? In squamous, the backbone was gem with platinum. In non-squamous, it was pemetrexed plus platinum. So chemo versus immunotherapy in first trial. Now come to the next one, 130. You look at chemo and you add immunotherapy. So nab-paclitaxel and nab-paclitaxel plus atezo. The reason they chose nab-pacli is we wanted a steroid-sparing chemotherapy regimen. So is the chemo alone enough or chemo plus atezo better? Now come to 3. There is 150. You look at chemo, you look at targeted therapy bevacizumab, and you add immunotherapy, and you want to see if addition of atezolizumab has any benefit, and is there improved benefit if bev is replaced by atezo. So basically, single agent immuno, combination chemo plus immuno targeted, VEGF targeted, and chemotherapy. These are the 3 main studies. Next slide, please. So let's go to the first study, which is the 110, IMPAR 110. Next slide. Correct. So this is monotherapy, immunotherapy, that is atezolizumab compared with platinum plus a chemotherapy combination. Next slide. In first line, non-small cell lung cancer. So stage 4, non-squamous and squamous, never received chemotherapy, PD-L1 selected, more than 1%, ALK EGFR negative. You compare them into 2 groups, chemo versus atezo. Atezo used to be a maintenance, and in the pemetrexed was the maintenance in the non-squamous arm. In the squamous arm, it was chemotherapy, and you would stop after 4 to 6 cycles. And go to the next slide. The primary endpoint was OS, and the secondary endpoints were PFS, ORR, etc. Now, if you look at the prevalence of PD-L1 expression in the atezo versus chemo arm, it was similar between both arms. Next slide. So the baseline characteristics were all balanced between the 2 arms, that is the atezo arm and the chemo arm, with respect to age, gender, ethnicity, tobacco, histology, etc., and performance status. Next slide. So the primary endpoint of OS in the PD-L1 subgroup, PD-L1 positive subgroup, the blue and the red curve, blue curve much better than the red curve. The median OS is improved by 7 months, 13 versus 20 months. So a significant difference in overall survival, and the immunotherapy group scoring over the chemotherapy group with a 40% benefit. The hazard ratio is 0.59, so close to a 41% benefit. Next slide, please. So this forest plot shows that the OS benefit was across all the groups. So not that a particular group benefited and the others didn't. The OS benefit is across all the groups. The OS benefit is seen. Next slide. Yeah. So the OS benefit was continued too. It is not that the curves come and meet at a particular point in the future. So the exploratory OS analysis in the high PD-L1, a continued OS improvement was observed in the atezo versus chemotherapy arm. So though the median OS difference is around 7 months, it is sustained. So that means that despite crossover, despite maintenance of atezo, the OS benefit is sustained. Next slide. So subsequent cancer therapies. So if you look at this slide, 35% of the patients in the control arm received subsequent chemoimmunotherapy. So what we should understand is when people switch from one group to another group, you have a limitation sometimes, and the benefit may not be seen. But despite almost 1/3 of patients receiving the standard of care or the arm A, atezolizumab, going into the atezolizumab arm, the OS benefit remained, though the hazard ratio came down from 0.59 to 0.76. But despite that, it was significant, and the OS benefit was still there, which shows that obviously atezo is scoring over the chemotherapy arm. Next slide. So OS hazard ratio more strongly favored atezo versus chemotherapy after adjusting the subsequent immunotherapy use, and that is what is shown in this graph. So basically, it is scoring over the immunotherapy and scoring across all the groups. Next slide. So Now, this is an interesting slide. This is about, is the OS benefit the same? We have two platforms, basically the DACO and the Ventana. And so you look at PDL1 from either of these two standpoints, both the platforms were allowed. The overall survival benefit was the same. So whichever, irrespective of the platform you use, if the PDL1 is high, immunotherapy scores over chemotherapy, and the platform doesn't matter. Next slide. So the secondary endpoints are PFS. Here, most of the studies actually look at PFS and we get approval based on PFS, but OS is the holy grail. So despite that, you look at the PFS too, there is a improvement in PFS, but OS is most important. We already have that. Next slide. Yes. So the PFS again, 8 months versus 5 months, even in the updated analysis, and it continues to show a PFS benefit. Next slide. Coming to the response rate, the response rate in atezolizumab is 40% versus 28%. So again, even on the secondary endpoint of overall response rate, atezolizumab scores over the chemotherapy arm. Next slide. Safety profile. So the atezolizumab arm demonstrated a favorable safety profile with chemotherapy, and we all know that with immunotherapy we are worried about all the inflammation, itis. But with chemotherapy we have more of cytopenias, etc. So if you look at the adverse events leading to treatment withdrawal, it is 6% in atezo versus 16%. If you look at the grade 3, grade 4 immune adverse events, those score higher, which is expected. We look for pancreatitis, thyroiditis, etc. So the adverse events grade 3 or 4 or grade 5 are much lower in immunotherapy compared to the chemotherapy arm, and leading to treatment withdrawal are also lesser in the immunotherapy arm. Next slide. This is a graphical description. The red scoring, the anemia, nausea, neutropenia, all are high in thrombocytopenia, are high in the chemotherapy arm, which is expected. And you come at the bottom line, hypothyroidism, pruritus, increased AST. These are the ones which you see in the with any standard immunotherapy. This is what we monitor each cycle. Next slide. And they are easy to manage and not worrisome. So how do you summarize? So this is a trial to look at immunotherapy versus chemotherapy. Immunotherapy scores over chemotherapy in the PDL1 positive group. The primary endpoint was overall survival, and overall survival there is a 40% benefit. The safety profile is consistent. It is much safer than chemotherapy, and the common inflammatory side effects are the ones to be watched out. Based on this, it got its regulatory approval as a first-line option in patients with PDL1 high NSCLC. Next slide. Now coming to the other study. This is IMPAR 150. So what is this? This is atezo plus chemo plus bev in metastatic non-small cell. Next slide. Non-squamous variety. So what they basically did here is, next slide please. They looked at chemotherapy, which is your paclitaxel carboplatin combination. They added bevacizumab to it, and on the other hand, they added atezolizumab, and they compared all these three arms. Next slide. So this is what we discussed. One arm is arm A, B, C. So arm A is atezo carboplatin, arm C is bev and carboplatin, arm B is a combination of the two. The primary endpoints in this study: overall survival, and investigator assess PFS. So what are the key clinical questions? Does addition of atezo to the triple combination add a benefit? And is there improved benefit if bev is replaced by atezo, or is atezo alone enough? Okay, so that is one. Next slide. So what's the rationale? Why do you want to do this? So we know VEB is a VEGF inhibitor, and it helps in activation of the T cell response. It normalizes the tumor cell vasculature, because of which there is an increased infiltration of T cells into the tumor. So VEB in one way is immunogenic. So it is normalizing the vasculature, helps in infiltration of T cells, and also helps in activation of the T cell response. So there is a change in the microenvironment because of this. You add chemotherapy to this, what happens is there is release of tumor antigens. So on one way, bev is helping. On the other side, chemotherapy helps by releasing tumor antigens. All this is enough for atezo to restore its anti-cancer immunity through T cell mediated cancer cell killing. So that is what you're trying to look, whether addition of chemo plus Bev helps Atezo, or you can do away with Bev and Atezo alone with chemo is enough. Next slide. So arm A, B, C, I'll just rush through some of these slides. The baseline characteristics as in all studies, almost studies were well balanced. 14 to 15% patients had liver mets at baseline, number one. 10% patients had EGFR mutations, and these patients were well balanced. 50-50 patients, PD-L1 and PD-L1 positive and PD-L1 negative. Next slide. So now look at the OS, which is the blue versus red, arm B versus arm C. So arm B is your Bev, Atezo, A, B, C, P. Arm B is, arm C is minus A, C, B, C, P. So you look at it, your median overall survival is higher, around 5 months. The hazard ratio is 0.8. So there is an overall survival benefit of adding atezolizumab to the triple combination. So ABCP has an OS benefit. Next slide. The improvement is around 4.5 months, which is statistically significant. Next slide. Now look at the overall response rates. The overall response rates are higher with the combination arm, 56%, 69% in the PD-L1 high group. So again, with respect to overall response rates, the combination arm scores over. Next slide. Yeah, so the OS benefit across all PD-L1 groups in the intent to treat population. So there is an OS benefit across the PD-L1 groups, but if you look at the PD-L1 high groups, they are the one who have derived the most benefit. So the median survival is almost double, which is excellent. So if you stratify your patients based on high PD-L1 and you put them on this regimen, you are going to derive the maximum benefit. Next slide, please. So this is basically, if you look at PD-L1 positive, PD-L1 negative, on the right side, your PD-L1 positive, the curves don't meet. If you look at the left side, the PD-L1 negative, the curves meet at some point in time. The benefit is there, but not much. So 27% versus 10% reduction in the risk or improvement in the OS or whatever. But the PD-L1 1, it is across both groups, but PD-L1 1 positive definitely score over. Next slide. So what is efficacy in the key subgroups? These are, there are two groups in which they have looked at basically. One is those patients who are EGFR positive and one those patients with liver mets. And let us see how the combination arm fares in each of these. Now coming to EGFR positive patients after standard EGFR TKIs. Next slide. So they had close to 120 EGFR mutation positive patients and sensitizing EGFR mutation in around 91. And those who had prior TKI was around 80 patients, 78. Next slide. Yeah, so the PFS curves, they separate at around 6 months. And in this group, the Atezo ABCP arm scores over, and there was a clinically meaningful PFS benefit, 9.7 months versus 6 months. So even in this EGFR group, heavily pretreated with EGFR, all existing EGFR agents, their PFS is higher when you give a ABCP regimen. Next slide. So what happens to the OS? We are more worried about OS. OS benefit in patients, do we really have? There is a continued clear separation of curves and OS benefit with the addition of ABCP. So the hazard ratios are even more impressive, 0.6. Yeah, and your OS is close to 30 months versus 18 months, which is almost 1 year of overall survival benefit. So if you look at arm B versus arm C, well, that is your ABCP versus your bevacizumab regimen. On the other hand, if you look at the other regimen, that is arm A versus arm C, the hazard ratio is 1 and there's no benefit which is observed between arm A and arm C. So clear cut in your EGFR patients, there is an OS benefit for ABCP, Atezo, Bev, Paclitaxel. Next slide. Again, this is a slide of OS benefit in patients with EGFR mutations with prior TKI, and the benefit is clear and sustained, and it is continuing. Next slide. How about the response rates? Impressive response rates in patients with the EGFR positive and the response has increased from 40% to close to 70% with the addition of atezolizumab, which is quite impressive. The numbers may look small, that is 24 patients or 18 patients, but nonetheless, the overall response rates are definitely better, close to double, with a CR rate of 6% versus 0%. Next slide. Now, how do the patients with liver metastasis fail? So we've already seen that around 15% of patients on this trial had liver mets. Let's see how they do with a combination of immuno plus targeted plus chemotherapy. Next slide. Again, there is a PFS benefit, and patients with mets, liver mets, have PFS of around 8 months versus 5 months. And if you look at an 18-month or 1.5 year landmark, 23% versus less than 2% patients have a progression-free survival benefit, which is quite remarkable. Next slide. Do we have an OS benefit? Yes, an OS benefit was observed, around 42% benefit, with an OS of around 13 months versus 9 months. And again, as usual, the curves separate early and they stay separated. So that means in your patients with liver mets, where you want a quicker response, the response comes pretty early, before they develop liver failure or jaundice, which precludes from giving further treatment. So the response comes early and the response is sustained, and you have an OS benefit. Next slide. Again, the overall survival goes up 41% versus 61%. So almost nearly doubled. Next slide. And any efficacy in other subgroups like bulky disease? Next slide. So in those patients who were categorized based on high disease burden versus low disease burden, there was an efficacy of arm B versus arm C, and there was a particular benefit. Next slide.
Sorry to conclude you, sir. Only 1 minute left for your session.
Yeah, so I would be grateful if you could just rush the slides when I tell you, please. Yes. So there is an overall survival benefit even with respect to the bulky sites of disease. Next slide. Next slide, please. So is it well tolerated? There was a higher proportion of grade 3-5 adverse events, but this was expected due to the additive effect of these drugs, and we have to manage the BEV-related side effects, which is hypertension, proteinuria, and immunotherapy-related side effects. Next slide. We'll go to the last few slides. So this is a summary. So ABCP combination has an OS benefit, especially in liver mets and those prior treated with EGFR. Next slide. Coming to the last part of the talk, which is the IMPAR 130. I'll keep it very brief. This is only to test whether chemo without atezo or chemo with atezo has shown overall survival benefit. You can go to the last slide here as a summary. So atezo was tested with atezo plus chemo versus chemotherapy. Next slide. And the primary endpoint was overall survival. Next slide. Again, the baseline characteristics is well balanced. There is an OS benefit. If you look at it, PFS benefit is also there, 1.5 month PFS benefit. Next slide. Overall survival, 18 versus 14 months, close to 4.5 months. Next slide. Across all the groups, it was relevant and maintained as in most studies. Next slide. You can rush through these slides. You can go to the last slide. The overall response rate was higher. Safety profile is well maintained. Conclusion. So this was a study providing an alternative whether chemotherapy plus chemoimmuno or plus chemo plus immuno is positive. There is a significant OS benefit, significant PS benefit across all strata, EGFR, liver mets, etc. So overall, all these studies have only proven that either alone in PDL1 positive or with chemotherapy in PDL1 unselected, or a combination ABCP in all patients who had received, prior TKI for sensitizing mutations or those with bulky or liver mets, atezolizumab has shown not only a PFS and overall response rate, but also a overall survival benefit with a manageable side effect profile. More importantly, excellent quality of life. Thank you again to the organizers for giving me an opportunity. Thank you.
Thank you, sir. It was a wonderful session. You have tried to cover majority of the things in a short time. it was a sweet and short session. Now the next topic would be panel discussion on early stage lung cancer. The moderator for this session would be Dr. Shikhar Kumar, consultant medical oncologist in Onco Centers, Hyderabad. And panelists for this session would be Dr. Hemant Udayraj sir, robotic surgical oncologist and director of surgical oncology and minimal access oncosurgery, Yashoda Hospital, Secunderabad. And Dr. Sanath, consultant medical oncologist, Basavataraka Indo-American Cancer Hospital in Hyderabad. And Dr. Shivaprasad Deshmukh, senior consultant radiation oncologist, Yashoda Hospital, Secunderabad. And Dr. Sandeep Kumar Tula, consultant radiation oncologist, Yashoda Hospital, Secunderabad. And Dr. L.M. Darlong, senior consultant thoracic surgery, head thoracic oncosurgery and chest wall deformity clinic, RGCI, Delhi. And even I would request Maunika ma'am and Sir Krishnamani sir also to participate with respect to medical oncology discussion. Shikhar, you can go ahead with your discussion.
Thank you, sir. I would request all the panelists to keep their video on and unmute themselves. We have 30 minutes and we have a lot to cover, so let us start right away. Please share my slides. All right, so we are going to discuss the different types of clinical situations that we would come across when dealing with a resectable lung cancer. There have been several developments in the treatment of resectable lung cancers, and till now we have heard about the advancements of treating advanced lung cancers with immunotherapy. But now immunotherapy has come into the picture in the treatment of resectable disease as well, and there have been several other developments as well. So let us try and see what developments have taken place and try and analyze some of the data in this setting. So this case, let us start with the case discussion. This is a 67-year-old gentleman who's a non-smoker who presents with mild cough, and an X-ray and a CT chest shows a lesion in the left apical lobe of the lung. Next slide. A PET CT scan is ordered, as you can see, and it shows a well-defined lesion in the left lung in the apical lobe region. Next. And this is the final impression of the report that has been given to us, that this is an intensely FDG avid nodular lesion in the apico-posterior region, and there is some pleural tags, and there is a non-FDG avid prevascular lymph node, and there is no evidence of any distant metastasis. Next. A biopsy is ordered from this lesion, which shows it to be an adenocarcinoma of the lung. Next, so starting with Dr. Hemant sir. So at this time point, how would you further work up this case, and what is your threshold for recommending a brain MRI scan in such kind of patients?
The first thing is before we proceed with any major procedure, though there is a slight controversy there, I would definitely like to have a pathological diagnosis. So we would proceed with, depending upon the location of the lesion, if it's peripheral or central, we would either do a bronch or we would do a transthoracic biopsy to confirm before we proceed. There is a wide variation in the guidelines where they say if it's obvious, then you could probably go ahead with your definitive therapy, whatever that may be. The second thing is to complete a proper mediastinal staging as well.
Yes. So, sir, as coming to the question here, when would you routinely order brain MRI scans as a part of your staging workup for such kind of cases?
Anything more than T2, I would go ahead.
All right. Next slide. Next. So if you look at the diagnostic yield of a brain MRI, this was a large retrospective analysis of more than 1,700 patients. And you can see that the diagnostic yield of a brain MRI is very low when it's a stage 1A. So as sir has rightly said, that any tumor size more than 3 to 4 centimeters, if it is 1B and above, then routinely ordering brain MRI scans as a part of the staging workup is essential, because then you are more likely to pick up a preclinical brain metastasis in such kind of scenarios. Next. So as you can see, even NCCN guidelines also, they do not really mention doing brain MRIs routinely in the evaluative workup of a stage 1A tumor. And from 1B onwards, brain MRIs can also becomes an expected test, which is done to complete your staging workup. So at this time point, your brain MRI is done and the PET scan is done, and you are thinking of taking up this case for surgery. So what kind of workup would you do for your mediastinal workup? Coming to the next slide. Yes. So how do you routinely do mediastinal staging in your practice?
Mediastinal staging, the basic purpose is to rule out an N2 disease. So the benefit of surgery is up to the level of N1 and very select N2, which is like almost theoretical if you look at our Indian practice. So basically you don't want an N2 on table, right? So that is the reason purpose of why we do a mediastinal workup.
Yes.
That means that you need to assess the N2 nodes and do a cytology, get a cytology from them to see that they are negative before you proceed with a major ablative procedure.
Yes.
So the current standard is to use a EUS guided FNA is the current standard.
Okay.
Right? And you might add a endo ultrasound as well. Yeah, I mean, what am I saying? Yeah. So basically, you do a bronch with a EUS and add a transesophageal endosono assessment as well.
All right. Next. So, Dr. Darlong, sir, what practical issues have you faced during your cases when you are working up them for your mediastinal workup? What are the common practical issues that you face routinely in your day-to-day practice?
In my practice, first of all, I would like to do MRI brain in this case. I mean, all lung cancers who go for surgery, I will make sure that they all get a MRI brain done, because we got 8% who have got occult mets, especially adenocarcinoma with a very high FDG uptake.
Yes, sir.
And coming to the mediastinal staging, I would personally see all the CT scans, I mean the contrast CT, especially this is the left side, and a mediastinal node in the pre-paratracheal is going to be entry. So it is very crucial. But a substantive node will not be, I mean, our pulmonologist, interventional pulmonologist will not catch that with a EBUS, a substantive what you call node. So, I mean, I would be very concerned about the contrast CT of the mediastinum. I'll see any nodes are suspicious. I would definitely go for a mediastinoscopy. This is specifically for left-sided lesions, because the pretracheal nodes are basically going to be entry. If I suspect they're going to be missed in a bronchoscopy because of the size, yeah, there may be some nodes, but not much of activity is there. But definitely nodes are there on a sub-centimeter side, looking a bit suspicious on the imaging, not on the PET view. So I would consider doing a EBUS, I mean, a mediastinoscopy on table, rule out entry disease. Otherwise, our routine is to do an EBUS in all cases.
EBUS, yeah. So from what I understand from both of you is that EBUS FNA or plus minus EUS FNA is the current standard of care for mediastinal staging, and you would probably require mediastinoscopy in some cases, but not routinely.
Yes.
Next slide. Next.
Yes.
Now, this is an important question. When would you not order invasive staging? And I want Dr. Hemant to answer this. Is there any particular situation when you would say, no, I would not do invasive mediastinal staging?
See, for a PET negative, right, and there's no suspicion on PET CT, and the lesion is a T1A, T1B, then probably you can avoid mediastinal staging.
All right. Next. So as we were discussing, both the surgeons have clearly told it that, you know, both EBUS FNA and EUS FNA is the current standard of care. But, you know, sometimes you can miss nodes, especially in stations 5 and 6. And that is when you would require either VATS or mediastinoscopy to pick up those nodes. But for the majority of cases, I think these two tests should suffice. Next. And this is what we were discussing, that if there is a peripherally located lesion and it's clinically stage 1A, the false negative rate of a PET is very, very low. It's only around 4 to 5%. And you could probably avoid doing invasive staging of the mediastinum in such cases. Next. In case, hypothetically, this is not a case of a clinically stage 1A, But if you were to come across a clinically stage 1A less than 2 centimeter tumor, what surgery would you offer as of today, sir? Dr. Hemant?
As of today, I would still go for a lobectomy, provided the patient is fit and his risk assessment is good. I would still go ahead with a lobectomy because that's the gold standard as on today. But yeah,
I mean, the recent trials have not changed your mind.
I would still favor going ahead with a lobectomy because if, like I've told you, if you have done a proper assessment and if the residual function is good, probably that's a little more control. Yes, segmentectomies are in as well. But for less than 2 centimeters, probably up to 1 centimeter T1A, I'm okay. But for a around 2 centimeter tumor, because I am worried that it will be upstaged in the pathology report, I would still offer a lobectomy and save segmentectomy for a highly, for a patient with more morbidity.
All right. Dr. Darlong, sir, in your practice, how often do you have to end up referring these kind of incidentally picked up lesions for SBRT because either the patients are medically inoperable or they refuse surgery? So do you come across this scenario in your practice, or do you take them up for surgery without any issues at all?
Yeah, most of the times, once anatomically they are resectable, it's the physiological part. If the physiology is bad, in that case, we encourage them to go for SBRT. Otherwise, we always, from the radiation side also, they always prefer going for surgery in such cases, because anatomically is resectable if the physiology is good. So, even the radiation colleagues prefer doing surgery, because we know post SBRT, we all talk about OS and all these things, but beyond that, there's always a higher risk of almost 2 to 4-fold increase in local recurrence. And how do you treat that? It's basically, again, chemotherapy, radiation. So the treatment increases. It's like saying, okay, I'll give you the OS of this, but you have more chance of, having chemotherapy, radiation to achieve the same OS, which can be achieved with surgery alone.
All right. Coming to our radiation colleagues, we have Dr. Sandeep here. So Dr. Sandeep, in your practice, in all the years that you were in PGI and now that you are in the private practice, have you ever come across any case being referred to you for SBRT for specifically this indication, clinically stage 1A, less than 2 centimeters? And if you have come across, how have you treated them? Post SBRT, once SBRT is done, what do you do next?
Actually, frankly speaking, I haven't seen any case which was referred in such an early stage without surgeries. No, I haven't seen a case as such.
Dr. Shiv Prasad, how about you?
I've never seen personally being referred for SBRT. I think maybe once that we have more data emerging from the ongoing trials, probably we might see few referrals.
Yeah, I think there is a lot of equipoise in the medical community about the role of surgery versus SBRT. Of course, it matters where the patient lands up first, but I think there's enough evidence accrued over several years now. I don't have the slides for SBRT specifically here, but there has been a lot of indirect comparison saying that the local control rates of SBRT are
it's comparable.
Yeah, it's comparable with surgery, and but what is more concerning to me is the disease-free survival, and let us have a look at that in the most recent trials of surgery. Next slide. So this is what I was referring to for clinically stage 1A peripheral tumors. There have been 2 large recent landmark trials. One was the Japanese JCOG trial, and the other one was the CalGB trial, and they assessed the role of segmentectomy in such kind of tumors. Next. And they preoperatively, although in a routine clinical practice you might avoid doing a mediastinal staging, as Dr. Hemant sir has said, but this being a trial setting, they still intraoperatively or preoperatively they did a frozen section. They ruled out hilar nodes, level 10 nodes, and they ruled out mediastinal nodes. And then they randomized these patients to lobectomy versus wedge resection. Primary endpoints were disease-free survival. Next. And they achieved their, it was a non-inferiority study, and it was proven that, at 5 years, virtually the curves are overlapping each other, and there was no difference in the 5-year disease-free survival. Next. And these were the conclusions that, at 5 years for such kind of tumors, you can probably get away with doing a sublobar resection, and probably these patients would have marginally better reduction in their, they would have marginally better lung function preservation. So there is an argument to offering a segmentectomy or wedge resection for these kind of tumors. But what is more concerning is that even for such excellently selected stage 1A lesions, which I think would come across very rarely in our practice, but still at 5 years, if you look at the disease-free survival, it is only 63%. That speaks about how aggressive this disease is, and it speaks about the need to further add some sort of treatment, either in the form of neoadjuvant or adjuvant treatment to improve these outcomes. And this is what will be the focus of our next discussion. Next. So this patient that we were discussing previously, this patient underwent the endoscopic ultrasound, and the patient did not have any enlarged mediastinal nodes. He was declared to be medically fit, and he underwent surgery. Next. And this is the histopathology report. It was a 2.9 centimeter tumor, and it was invading the visceral pleura, hence it was PT2, and 2 nodes were positive in station 10 and 11, so making it PT2N1, that is stage 2B disease. Next. Now, coming to the medical oncologist. Next. Now, this case was operated upfront, but had this case been discussed in a MDT before surgery, would you have asked for any particular biomarker testing, Dr. Sanath?
So, yes, I would like to ask both EGFR and PDL1.
Why, sir? Why would you want to test these things before surgery itself? What is your reason for testing EGFR, ALK, and PDL1 before surgery?
No, not before surgery. After surgery, I would like to ask. Not before surgery.
You would not have asked it for PDL1 before surgery?
So 1B, there is the data is there for 1B also. So it depends. So 1B, there is also data. Edzolizumab data is there. So
no, but specifically for this case, it was a fairly big tumor.
Routinely we do after surgery only.
After surgery, yes. But had this been discussed in a MDT, Dr. Monica ma'am, if you're there, like if this case had been discussed in an MDT, would you have asked for any biomarker testing on the biopsy sample that was shown initially, the biopsy sample which showed adenocarcinoma? Would you have ordered any biomarker testing? Is Dr. Monica here? Dr. Krishnamani sir, are you there? Okay, I think both of them are not there. So let us go to the next slide. Now, this is the reason why I want to bring this forward and discuss the role of preoperative biomarker testing. This is the phase 2 NADIM trial in which neoadjuvant chemotherapy was given for a resectable non-small cell lung cancer, and 3 cycles of paclitaxel, carboplatin, and nivolumab were given. And although this is a phase 2 trial, this had some pretty astonishing results with the PathCR rates of 63%. And an excellent 3-year PFS and overall survival outcomes. And a confirmatory phase 3 trial was done subsequently. Next slide. This was the landmark phase 3 trial. Next slide, please. The Checkmate 816. This took resectable cancers of stage 1B to 3A. It stratified them as per PDL1 expression, more than 1% or less than 1%. It ruled out EGFR and ALK mutations, and it randomized patients to receive 3 cycles of preoperative chemotherapy or 3 cycles of preoperative chemotherapy plus nivolumab. So only 3 doses of nivolumab were given before surgery, and adjuvant chemo was optional. And the primary endpoint were 2. One was the PathCR, and second was the event-free survival. Next slide. Next slide, please. Yeah. So you can see the PathCR rates. They were significantly better. There was a significant difference in PathCR rates in stage 2A and 2B patients. Almost 24% PathCR with nivolumab plus chemo was seen. Next slide. And the trial achieved its other primary endpoint of improvement in event-free survival. That with chemotherapy alone arm it was 20 months, and with immunochemo arm it was 31.6 months with a good hazard ratio of 0.63. So coming to the next slide. And this is very important. Why I asked for biomarker testing before surgery is the PDL1 less than 1% group, it was not significant. As you can see, it was a hazard ratio of 0.85. But the higher the PDL1 expression, the more the likelihood of benefit with adding preoperative nivolumab. And in fact, the PDL1 more than 50% group, you can see the hazard ratio of 0.24. It was heavily in favor of immunochemotherapy, and this group had a PAT-CR rate of 45%. So definitely PD-L1 biomarker testing before surgery appears to have some impact, because adding preoperative 3 doses of nivolumab when the tumor is intact with its intact blood supply and adding chemo immuno, and you are having this kind of unheard of PAT-CR rates with a long-term EFS data also is definitely worth considering. Next slide. And this is the outcomes in patients who achieve PAT-CR. Look at the curves; they are virtually straight. They have excellent median EFS. They were not reached, and of course, those who did not achieve PAT-CR had inferior outcomes. So this is further proof of concept that nivolumab pre-surgery, as per this phase 3 trial, has definitely come into the picture here. And with further passage of time, this will probably become a standard of care, if not already. Next slide. Okay, so this case was not discussed in the MDT and it was operated upfront, but now the patient has come to you, sir, for a post-operative adjuvant treatment. At this time point, what biomarker tests would you order?
So I would like to order both EGFR and PD-L1.
Correct. We will discuss the reasons for that in the next slides. Next. So, sir, what do you expect from testing PD-L1? Why are you doing PD-L1 testing here?
So it is N1 disease. So if it is EGFR negative and PD-L1 positive, then we can discuss about the after chemotherapy. We can give atezolizumab. There is a EFS benefit is there. So who are PD-L1 positive. So that's why we will discuss the option of immunotherapy. We can discuss the option.
Absolutely, sir. And in this setting, there are 2 landmark phase 3 trials. The PEARLS trial has been published just last month in Lancet, and the Empower 010 was a 1-year-old study. Both studies, they studied patients who had been operated upfront, and then they were given adjuvant chemotherapy. Chemotherapy was not mandatory in PEARLS, but majority received it, and they were randomized to receive, after completing chemo, 1 year of immunotherapy versus only observation. And atezolizumab versus best supportive care was in the Empower trial, and in PEARLS trial it was pembrolizumab. And what is to be noted is that a flaw of both these trials is that they did not mandate EGFR and ALK testing, and that is one of the main criticisms of both these studies. And because in fact in the PEARLS study, almost 60% patients they did not know their EGFR ALK status, so that could have biased the results. Next slide. So the Empower 010 study, in the PD-L1 more than 1% group, it achieved its endpoint because the disease-free survival was superior and the hazard ratio was excellent. It was 0.66, and you can see a early and a consistent separation of the DFS curves in the 2 arms. And then based on these results, it was approved by FDA for adjuvant treatment in patients who have been resected and who have a PD-L1 of more than 1%. Next. Next. And this is very important to note. There has been a discrepancy in the 2 trials as far as the PD-L1 data is concerned. We saw in Checkmate 816 that the higher the PD-L1 expression, the better the PAT-CR, the better the outcomes in EFS also. Similar pattern has been seen with atezolizumab in the Empower trial. You can see that the hazard ratio is consistently improving the more the PD-L1 expression. But something unexpected has come up in the PEARLS trial. The PD-L1 more than 50% group, that technically we should have had the best outcomes with pembrolizumab. Here the hazard ratio is 0.82 and it is not significant. So I read the paper today and I tried to find out what rationale the authors have given for this discrepancy. They don't know why this has happened. They have theorized that the control arm has done very well for some unknown reason, and this is why the hazard ratio is not significant. But this is an important negative study for now, and further long-term follow-up is needed to know why this high PD-L1 group has not done well with adjuvant pembrolizumab. Next. So, sir, this patient, you have ordered EGFR testing as you said, and EGFR mutation has come. It's exon 21, L858R. Now, what would you do, sir? What would be your next approach?
So first, I would like to complete my adjuvant chemotherapy.
All
because
right.
it is a gold standard, and it has both progression-free survival and overall survival.
Absolutely.
And most of the patients are affordable.
Absolutely.
So after that, then I would like to discuss about the EGFR inhibitor, that is osimertinib. But I will discuss about the problems and about to complete the data also, because it is patient has to take nearly 3 years with that osimertinib, and we don't have any overall survival data. And even the latest curves of DFS, they are merging. So I will discuss all the intricacies involved in this. So then I will give the option of osimertinib.
Absolutely, absolutely, sir. I absolutely agree with you on this point, and we'll quickly go through the slides which explain the very thing that you have mentioned. Next, as sir has already said, chemotherapy is still the gold standard, although the 5-year OS benefit is modest, but it should be offered to all patients if they are fit to take it. Next, and stage 1B is still controversial because the latest meta-analysis showed that this is not significantly improved in stage 1B. But stage 2 onwards, adjuvant chemotherapy for 4 cycles should be given, cisplatin-based doublets. You can choose whichever doublet you want to give. Next slide. But yes, this is the landmark trial which has created a lot of controversy, lot of discussion, lot of opinions are being thrown around here and there. That some say that yes, it should be given, some say no, wait for OS data. Let us look at the recent update presented in ESMO. And I came across this excellent analysis by Dr. Sanjay Popat at the ESMO conference concluded recently, and I'm going to share some of his thoughts with you people. Next slide. We already know about the ADAURA trial that one of the criticisms is that adjuvant chemotherapy was not mandated for everybody. 40% patients they did not receive it. Next. And brain imaging at randomization was not mandatory by MRI, but yes, some brain imaging was done at baseline, and 3 years of osimertinib versus placebo was the randomization. Next. Of course, the DFS curves are drastic. There was nothing seen like it before in the era of targeted therapy for resectable lung cancer. And the hazard ratio was staggering. It was 0.17. Even at the long-term data at ESMO, the hazard ratio is still excellent. It's 0.23. But some interesting observations have emerged. Next. If you look at stage-wise, the hazard ratio for stage 1B is not as impressive as that for stage 2 and stage 3A. And at the recent follow-up, the hazard ratio for stage 1B has further become 0.50 from the initial 0.41, indicating that 1Bs are probably cured with chemotherapy alone, and not enough events are taking place to justify adjuvant osimertinib in this population. Next. And look at these curves. These are the updated curves for the disease-free survival. And if you look at the stage 2 and the stage 3A curves, once your 3-year osimertinib is finishing, after that, the DFS curve starts dipping quite sharply for both stage 2 and stage 3As, which, as Dr. Sanjay Popat clearly tells so well, that probably it is because osimertinib is just delaying the relapse. Until you keep giving it, it works. But the moment the osimertinib stops, the relapse rates increase sharply. Next. So like I said, we don't yet know the optimal duration of osimertinib. Why 3 years was chosen? Is it enough? We don't know the answers for that. Is it simply delaying relapse? And if so, is the huge DFS benefit meaningful to patients and payers? Would these patients have the same survival, which ultimately this is what matters to them? Would they have the same survival if they were retreated with osimertinib at the time of relapse? We don't know the answers for that yet. Next. And a similar pattern has been seen with the adjuvant TKI trials done in the pre-osimertinib era. You can see that once the TKI stops, the DFS curves start dropping down, and none of these trials have shown an improvement in overall survival, even though the initial trial data showed improvement in disease-free survival in some of them. Next. And we know that osimertinib works excellently. It reduces both local relapse in the lung as well as systemic relapse. But what about those patients who relapse once you stop osimertinib? Does it mean that they are dependent on osimertinib and you should re-challenge them? What is the pattern of the resistance emerging? We don't know we don't have all the answers. Next. And this is another interesting graph which I could see, is that once your 36 months of osimertinib is done, after that time point, the CNS disease recurrence rates start rising up. So this definitely means that as long as the osimertinib is going on, it prevents CNS relapse. But the moment you stop it, the CNS relapse rates start rising. So this is something to consider. Next. So this is what is his opinion, and I agree with this, that although the DFS effect is strong and it is clinically impactful, but still no mature OS data is present. And now we are seeing the TKI waning effect on treatment discontinuation in stage 2 and stage 3. And while on treatment, it is neuroprotective. But what about those patients when once you stop osimertinib, then you see that the CNS recurrence rates are rising up. Next. So we don't yet know the optimal duration of osimertinib, and we don't know whether it's simply delaying relapse. And we still are waiting for the most important endpoint of all, that is overall survival. Next. So coming to the last point, coming to the discussion of whether this patient was if this patient was a PN2, it had been operated, and an N2 node station had come positive. At this point, I would like to ask Dr. Shivaprasad, would you offer post-operative RT in this case if if the PN2 status was positive?
No, Dr. Shikhar, not in this case. In the backdrop of lung ART trial, I wouldn't recommend a post-op because the toxicity clearly outweighs the benefit in this case.
Is there any case of resectable lung cancer where post-surgery you would strongly counsel the patient for post-operative RT?
Yes, because the lung ART trial itself had lots of flaws because I think there might still be some subsets of patients who might actually benefit, especially in the cases with extra capsular extension and also with multi-station N2 disease. So we do not know, and also I think we do not know the role of RT against the backdrop of immunotherapy also. So these questions still remains to be answered. And but in this case, I wouldn't recommend port.
Dr. Sandeep, do you agree with Dr. Shivaprasad that in extra capsular extension and in multi-station N2, you would still consider giving
yes,
RT?
Yes, I would still consider, because in the lung ART trial, the technique which they used was only 3-dimensional radiation, 3D CRT, not IMRT. Most of the cases, 89% of the cases, they have used only 3D CRT. So just up to now, when you speak about immunotherapy or when you speak about targeted therapy, you are speaking advancements. But when we speak about radiotherapy, I mean the trial, ART trial, they have used the old age technique like 3D CRT. So maybe in the, if you use IMRT, maybe we can see that there will be improvement in the survival. For example, in the Michigan oncology group, they are trying to use the same standard like lung ART trial with the IMRT. They have seen that mean lung dose and the mean heart dose were very much lesser when compared to lung ART trial. And yes, the time will answer whether we have to use the post-operative RT in N2 disease.
Correct me if I'm wrong, but lung ART is the only large phase 3 trial in the modern era. All the previous trials were with even more older techniques like 2D field. And with IMRT, your main concern would be to reduce the toxicity. But how would you be able to improve survival by IMRT unless you are doing some sort of dose escalation, which is still not recommended in post-operative cases?
But Dr. Shikhar, I think there is improvement with regards to mediastinal relapse, even with this trial.
Yes.
Even though,
Yes.
So I think again, so I think the mediastinal relapse, if I am not wrong, it's 70% as opposed to around 85% in the
So let's discuss that. Next slide. So this is the trial that we are referring to. This is the, I think the only largest phase 3 trial in the modern era, which although did not use IMRT, but it was still conformal radiation. And this randomized patients with proven N2 status to either observation or conformal RT, and the primary endpoint was an acceptable endpoint of disease-free survival. Next slide. And this trial had a hypothesis that it wanted to improve the 3-year DFS by 12%. It's a valid hypothesis. Next slide. And if you look at the patient demographics, what we were discussing at multi-station N2 nodes. So quite a few patients, I mean, one in every 4 patients had multiple N2 nodes in this trial. So it's not as if these patients were underrepresented in the lung art trial. And adjuvant chemotherapy also, it was given to practically most patients. So the standard of care as of today was definitely followed in these patients. Next slide. And majority of these patients underwent lobectomies. Very few of them had to undergo pneumonectomies. And if you see the PN2 status, yeah, do we still have Dr. Hemant with us?
Yeah, I'm very much here.
Sir, what would you, how would you comment on this PN2 status and this post-op findings? Is this something which is the standard as of today? Is this what you would normally expect in your large series of resected lung cancers regarding PN1, PN2 status?
So N2 here says that most N2 is like, yeah, 4, 5, 7, right?
Yes.
7 is subcarinal, right?
Yes.
And 4, 5, 7 are the most commonly involved stations.
Yes. Yes. So this would be a reflective of our usual practice, isn't it? That these are the most commonly involved nodes, and quite a few of these patients had multiple N2 nodes involvement. So it is a reflective of our routine practice. Next slide.
Yes, I would agree.
Next slide. So this was the outcomes that were reported, and this trial failed to achieve a significant improvement in the 3-year disease-free survival. And as you can see that the 12% hypothesis was not met. Next slide. But this is what Dr. Shiv Prasad was referring to, and he's right here that in the there were more mediastinal relapses in the control arm. The port arm had lesser mediastinal relapses. But if you look at the other causes of death, that is cardiopulmonary toxicity and other port-related toxicities, they increase the number of events on the port arm, and this is why probably when the overall DFS curves were calculated, it did not result in a significant improvement. So I think that is the end of our discussion. Next slide. Yes, so thank you everybody for a very invigorating and an excellent panel discussion. And if anyone has any further comments, you can please make it now.
I just want to add a point regarding SBRT versus surgery. Only 2 randomized control trials are still going on, stable trial and veterans trial. So we have to wait for that result so that we can comment whether surgery versus SBRT, which is superior, or almost if SBRT will be equivalent to surgery. So that's all. Thank you.
Yes, I think we are waiting for that data. But
Yeah.
as of now, the data, whatever the data that we have, it does suggest that yes, local control rates are probably equivalent with both the modalities. It is what we do after the local modality is what ultimately determines how the patient will do in a in the long terms. But yes, let us see. Let us hope for the best. Thank you, everybody.
Good discussion on early stage lung cancer, Dr. Shikhar. Sir, any closing comments from you, sir, Hemant sir, with respect to your surgical part and all? Anything you wanted to add as regarding the surgical practices?
Yeah, surgical morbidity has significantly come down after this minimal access surgery. After when we were postgraduates and initial days of our practice, it was all open surgery, and after adoption of VATS, I think it is like significantly changed in terms of morbidity and also the standardization of the lymph nodal yield in lymph nodal dissections now. I think that makes a significant difference in the overall outcome. So I think surgical quality was also improved significantly apart from the advances in medical oncology. I think Dr. Darlong also would agree with me.
Dr. Darlong, you are on mute. Please unmute.
Yeah, I would agree with sir. I mean, we are maximally invasive. Invasive, but access is very small now. The extent of local control, like we're talking about SB radiation and all that, mediastinal node clearance. I mean, local wise, it's become more radical, but the access is very small. I think the game changer now will be basically immunotherapy, and I feel that we are going basically towards what you call bimodality. That's basically surgery and systemic, and that too with immunotherapy. radiation definitely has a role. I mean, it is still going to be having a role, like we are having a lot in oligometastatic disease, stage 4 disease, where radiation is now very much part of local conservation therapy. So I think the space is going to open up more for surgeons in the locally advanced setting with the coming of immunotherapy. The NEAM phase 2 trial, which is specifically for multi-station N2 disease, is very, very encouraging. And I think our medical oncologists also agree with that. The N2 disease, which was said to be a non-surgical candidate, is now getting accepted more as a surgical modality now. I think the field is getting more and more open for, I think, lung cancer.
Yeah, I would agree too. I think the good times are ahead because of the, neoadjuvant strategies which are improving day by day. I think it opens out a significant population of patients who were otherwise not surgical or curative candidates. I think good times ahead. I think we should see how we can combine all these strategies to get probably most of the surgeries in future would be salvage. Going by the data that we see. But that also brings in a huge population of otherwise patients who are considered to be inoperable or non-curable segment. We'll have to wait and watch. Interesting times.
Thank you, sir, for your comments and suggestions. And now we will move on to the next talk.
Thank you for the opportunity, Rajesh.
Now we will be moving on to the next talk. This special session is sponsored by Astra. And the topic for now is decoding treatment options for EGFR positive NSCLC. To talk on the same, I would like to invite Dr. Rajesh Kota, Medical Director and Head of the Department Medical Oncology, Nagarjuna Cancer Center, Vijayawada.
Yeah, thank you, Dr. Rajesh. Can you see me? And if someone can put on my slides from AstraZeneca team.
Yeah. Ankit, you can help sir.
By the way, that was an excellent discussion by Dr. Shikhar about the adjuvant treatment strategies. And the evidence for adjuvant, as we see, is still emerging, but we have a clear-cut winner in the metastatic setting. So we'll just be focusing on the use of osimertinib in the metastatic setting. Can we go to the next slide? Next slide, please. The usual epidemiological data. Lung cancer, it's almost 11% of all cancers detected and causing about 1/5 of total cancer deaths, about 18%. Next slide. So what determines our first choice in the metastatic EGFR mutated non-small cell lung cancer patients? So all the trials starting from the first generation TKIs, the approvals have been based on the better progression-free survivals when compared to chemotherapeutic agents at that point of time. And when we move ahead in times and when the second generation and third generation TKIs have come into the picture, still the PFS is the basis for approvals, and the second generation and third generation TKIs are being compared with the first generation TKIs in the approval processes. So next slide. So the secondary endpoints like overall survival, overall response rates, presence or absence of brain metastasis, safety and toxicity of the TKIs, the quality of a patient's life, and the number of patients able to receive subsequent therapies. All these are subsequent endpoints that have come up in the trials we are looking at. Next slide. So as you can see, the progression-free survival have jumped almost doubled from the 9.5 months progression-free survival we have seen in the IPASS. That was the landmark trial that approved gefnib across EGFR mutated non-small cell lung cancer patients. We are now looking at a PFS of 19, close to 19 months in the FLORA trial, where they have used osimertinib as the first line TKI in the metastatic EGFR mutated NSCLC setting. Next slide. So if you look at the, though it is a cross trial comparison, you can look at the patients or subgroups that have been included in the trials. So if you look at the LUX-Lung 7, we come to know that 16% of patients included in the trial had stable brain mets, whereas the dacometinib trial, that is the Archer 1050, all patients with brain mets were excluded, and in the FLORA, the stable brain mets, which comprised around 1/5 of the population, almost 19% of the study population had stable brain mets at inclusion. So even with the inclusion of brain mets population, you can see the separation of curves immediately from the second month onwards in the FLORA trial. So though it is a cross-trial comparison, brain mets being a poor prognostic feature, and and osimertinib with its nature being able to cross the blood-brain barrier, we can see the immediate separation of curves within the first or second month itself. Next slide. Next slide. So if you look at the overall response rates also, so in the LUX-Lung 7 and the Archer 1050, the overall response rates were around 70-75%. And if you look at the FLORA, the overall response rates improved to 80%. So it is not a significant jump in the number, but nonetheless, the highest overall response rates we are observing is with the third generation TKI, that is the osimertinib. Next slide. And if you look at the duration of response, that is one interesting thing. So if you look at the duration of response, the median duration of response in the osimertinib subgroup was 17 months, whereas it is 8.5 months in the standard of care. Next slide. So till now, all the EGFR TKIs had excellent PFS benefit over chemotherapy, but we could not achieve an overall survival benefit in the long run. FLORA is the first trial to establish an overall survival benefit with the usage of osimertinib in the first line setting, with a median overall survival of more than 3 years, almost 7 to 8 months improvement in the overall survival. And if you look at the 1 year, 2 year, and 3 year time points, clearly even at third year also, at the end of third year also, almost 10% more patients are still alive on when they were started on osimertinib as the first line agent. So first time any TKI has shown an improvement in overall survival, it is osimertinib. Next slide. When used in the first line setting. So if you look at the LUX-Lung 7 and Archer 1050, both of them, though they have significantly improved the PFS when compared with the first generation TKIs by about 3 to 4 months, it could not get translated into the overall survival benefit. Next slide. And the overall response rates are also not so different. And if you look at the Archer 1050, it is a stepwise analysis of the data. So the overall response rate, though the PFS was better than the comparator arm, the overall response rate didn't achieve statistical significance. That's why the OS benefit, though it is statistically more, it did not meet its significance. So the p-value is not given for the overall survival benefit, that is 4 or 5 months better in the dacometinib arm. Next slide. Next slide, please. Yeah. So if you look at this slide, even at the end of 3 years, almost 28%, that is close to a third of patients are still on the drug. So, it is when you compare that with only 9%, it is 3-fold jump higher at the end of 3 months. So patients taking on osimertinib for 3 years, the one underlying point here we have to look at it is a very stable and a very easy drug to order, and the patients find it easy to continue to take osimertinib. Though we have a little surprising side effects we have observed in the real world data. In the coming slides, we'll discuss about that. But osimertinib as such is a easy drug to prescribe. Next slide. Yeah, if you look at the CNS efficacy, so as we all know, FLORA included patients with CNS metastasis that were stable at entry. They comprised about 19-20% of the study population. As I said earlier, the separation of curves starts immediately within a month or two. So CNS progression events occurred in 6% of the patients on osimertinib, while it was 15% in the standard of care arm. Next slide, and you can see the hazard ratios almost 0.47. That is 50% of the patients had a benefit with osimertinib. This is the full subset analysis. So the median PFS in the patients with CNS metastasis didn't reach in the osimertinib arm, whereas it was only 14 months in the standard of care arm. Next slide. And the CNS PFS was statistically significant with osimertinib when compared with the comparator arm. This is the same CNS response slide. Next slide. So if you look at the safety data, dacometinib, though I have a little experience with dacometinib, it is a toxic drug, as we can see from the safety data from the Archer 1050. As much as 60% of the patients reported any of grade 3, grade 4 adverse events, be it skin toxicity, be it diarrhea, be it prolonged QT intervals, be it decreased appetite. So almost 2/3 of the patients had grade 3 or 4 adverse events with dacometinib. In the afatinib trial also, almost 1/3 of them had grade 3 or greater adverse events. Whereas the osimertinib group in the FLORA trial reported grade 3 and grade 4 adverse events was only 18-20%. Next slide. And if you can see the class side effects of skin toxicity, paronychia, diarrhea, and stomatitis, it is hardly 1-2% in the osimertinib group, though it is a cross-trial comparison. But if you can look at the second generation TKIs, the skin toxicities and diarrheas were much higher than the osimertinib. Next slide. So if you look at the dose reductions, so I hardly remember any patient asking for a dose reduction or reducing the dose while the patient is on osimertinib. So similar is the case with the first generation TKI, geftinib. So we had issues with erlotinib. We used to reduce dose with erlotinib. But the third generation TKI, that is the osimertinib, I hardly remember any patients requiring dose reductions. As compared to the Lux Lung and the Archer, where they had almost 40-60%, 40% in the Lux Lung 7 and 67% in the Archer 1050, where patients required dose reductions. In the FLORA, it was hardly 4-5%. Next slide. The quality of life also, not much deterioration of quality of life. Actually, the quality of life is improved in the FLORA trial, and the Archer just noted that the global quality of life was just maintained in the dacometinib when compared with the comparator first generation TKI. So in the quality of life goalpost also, the FLORA had a much better outcomes when compared with first or second generation TKIs. Next slide. So coming to the number of patients able to receive second line therapy in EGFR mutated advanced non-small cell lung cancers. So if you look at this slide, so if we start with 10 patients of EGFR mutated NSCLC patients on first generation or afatinib, that is second generation TKI, 70 almost 2/3 to 70% of the patients go on to receive second line therapy, and the rest die during the first line or receive only palliative care upon progression. So they might not even get tested for the resistant mutation, that is the T790M, before going to the second line. So patients receiving going on to receive the second line, only 60-70% get tested for a T790M mutation, and most of the patients might not be eligible for tissue biopsy because of their general condition or insufficient tissue from the biopsy or inaccessible sites. So, and some of them might get false negative result on the liquid biopsies. So around 50% of the patients do get tested for T790M mutation, and if they get it positive, we end up giving only 30% of the patients who are eligible for second line osimertinib. So 7 out of 10 patients who were started on first or second generation TKIs might not be able to receive osimertinib in the second line. And at this point of time, we are not able to predict who will develop this T790M mutation, T790M resistance mechanism. Next slide. Yeah, if you look at these various trials, starting from IPAS to URTAC, Optimal, Ensure, LuxLung series, we get to see that around 50 to 60% in majority of the patient, majority of the trials receive subsequent therapy. Approximately 1/3 will not have access to second line treatment in this setting, in the EGFR mutated advanced lung cancer setting. Next slide. Next slide. Yeah. So we'll see some real world evidence. When we look at the real world evidence of T790M mutation after afatinib, in a Japanese study, only 43% of the total 37 patients acquired T790M after first line afatinib. And in this Taiwanese study, around half of 48% of 42 patients were rebiopsied. Only half could get a rebiopsy. And only 1/3 of them were identified to be harboring the T790M mutation. Next slide. So less than 50% patients put on afatinib acquire T790M mutation. So next slide. So is there an ideal sequence of giving EGFR TKIs? So starting with the first or second generation EGFR TKIs and then treating those who develop T790M mutation with osimertinib. Is it an optimal choice? In the real world, it doesn't look so, because right now we are not smart enough to figure out which patients will develop EGFR T790M mutations, and not everyone will be physically fit to receive additional treatment, and 30% of the patients don't receive any subsequent therapy at all after starting with the first or second generation TKI. And we are not at perfect in getting the liquid biopsies right always. And osimertinib is significantly associated with the overall survival. The overall survival benefit with osimertinib is cannot be neglected when used in the first line. Next slide. So there are some uncontrollable factors not in our hand in sequencing. So some patients might be toxic to the first or second generation drugs, and we cannot predict the T790M mutation. We don't know which patient gets this resistant mutation, which patient doesn't get, and sites of progression. Sometimes it will be difficult for us to get a rebiopsy from a difficult site of progression. And as the patient lives with cancer and he acquires concurrent morbidity, it might be difficult for us to treat in the second or third line settings. And patient's choice. So maybe the patient might be willing to get treated with the best possible drug in the first line. And when we offer in the second or third lines, maybe the financial constraints also come into the picture. Next slide. So we'll see a couple of studies where they have used first line osimertinib, and some unexpected side effects that were not reported in the FLORA have come up in a slightly higher percentage of patients. Next slide. Next slide. Yeah. So if we look at this FLOWER study, that is first line osimertinib in the real world, an inter-regional prospective study done in Italy across 9 centers. So around 126 patients were treated with first line osimertinib. And if you look at the brain mets at baseline, it is higher than what we have seen in this trial. It is almost 30% patients had brain mets at baseline, and almost 12% to 13% patients had a poor performance status of more than 2. So if you look at the time to treatment discontinuation, it actually didn't reach. It is almost 25.3 months. That is the time to treatment discontinuation, and medium time to treatment discontinuation in patients. When we compared patients with symptoms and without symptoms, patients with symptoms had medium time to treatment discontinuation at 18.8 months, and it didn't reach in the patients without symptoms. And if the patients had less than 3 metastatic sites, the time to median treatment discontinuation is better at more than 21 months. And if you look at the median PFS, it is almost equivalent to the trial data of 18.9 months. And patients without having brain metastasis, the median PFS is still not reached in this trial. And patients having brain metastasis, the median PFS was 13 months. And median PFS in patients without symptoms, we didn't reach the median PFS, and patients having symptoms, the median PFS is 15.5 months in this trial. Next slide. And if you look at the complete responses, there were no complete responses, and almost clinical benefit ratio was around 90-95%.
Sorry to interrupt you, sir.
Yeah.
The time is running out.
Yeah. I just have one more study. That's all. Right. So if you look at the common adverse events observed, so venous thromboembolism, that was not discussed or that was not highlighted in the trial. Almost 10% patients had any grade venous thromboembolism, and 8% had grade 3, grade 4 venous thromboembolism. Next slide. Osimertinib in this trial has confirmed the effectiveness, and we have come up with a new side effect. And this is done in Japan in 538 patients. And if you look at the brain mets at baseline, it is all again 31%. And they have stratified across PDL1 subgroups also. Next slide. And in these two studies, the L858R mutation was almost half in both the studies, in the Italy study and the Japanese study, which is a little higher, what I feel, when compared to the Indian subgroup. And if you look at the adverse events of this real-world study, pneumonitis. So patients had to discontinue pneumonitis because of pneumonitis in a total of 219 discontinuations. That is, out of 538 patients, 40% patients discontinued due to various reasons, either due to progression or side effects. 1/4 of all discontinuations are due to pneumonitis. And again, this is something new, and I had a patient which I had to discontinue because of pneumonitis. So I don't have big numbers, but I have seen these kind of side effects in with the use of osimertinib, and that too come in 2nd or 3rd months. So it comes real quick. It is not like the more time we give osimertinib, the higher the chances of pneumonitis. So the patients present in 2nd or 3rd months of starting osimertinib. Next slide. And the PFS was as good as the trial data. And this is the 3rd real-world study. It is done across USA, Japan, Germany, and China. Again, 1/3 patients had brain mets at baseline, and 15% were poor general condition patients, PS of more than 2. And the exon 19 to 21 ratio was 51%, 19, and 33% exon 21. Next slide. Next slide. Next slide. So in that trial also, the time to treatment discontinuation was better in the osimertinib arm, are comparable to the trial data. And if you look at the guidelines, osimertinib is the preferred guideline, whether you detect the EGFR mutation before starting any systemic therapy, or if you come to know about the mutation after starting the therapy, you can complete the planned course, or even you can interrupt and start osimertinib in the first line setting. Next slide. And the strength of recommendation is very strong for osimertinib in the first line use based on the PFS, more than the PFS, the 7 to 8 months improvement in the OS data. Next slide. So to summarize, osimertinib is the only EGFR TKI till date to have demonstrated clinically meaningful and statistically significant improvement in overall survival, and the median OS benefit of greater than 3 years. It is the new benchmark for upcoming EGFR TKIs for the ongoing clinical trials. And the first time Flora is the first time that an EGFR TKI is translated PFS into OS benefit, and 1/3 of the patients are still taking osimertinib at the end of 3 years. It is the only drug to have had significant response rates in brain metastasis and patients harboring T790M mutations. And it is a fairly safe drug, and patients continue to take the drug at the prescribed 80 mg dose without any significant adverse events. Sequencing in the real world, maybe we can consider, we do practically have a lot of financial constraints resisting us from prescribing osimertinib, but in an ideal situation, osimertinib should be the first line choice for EGFR mutated advanced lung cancer. And because 70% of the patients who were started on prior generation TKIs would not have received osimertinib. So these data confirm osimertinib as the first line standard of care in advanced EGFR mutated non-small cell lung cancers. Next slide. I think with that I conclude my talk.
Thank you, Dr. Rajesh Kota, for your excellent talk on treatment options for metastatic EGFR and NSCLC. I would request other speakers to stick on to time, because we have got already running late by 20 minutes. So each speaker, please stick on to the time for the next 20 minutes. Next, I would request my friend Dr. Sanath, consultant medical oncologist, Basavataraka Indo-American Cancer Hospital, to speak on first line ALK positive NSCLC treatment options. Sanath, over to you.
Thank you, Rajesh, for providing me this opportunity. So I will share it. So my talk is ceritinib, a frontier in the first line treatment of all positive non-small cell lung cancers. These are my disclaimers. So we all know around 90%, 87% of the lung adenocarcinoma patients will have actionable, some actionable driver mutations. Around 64% of squamous cell carcinoma will have some actionable driver mutation. And we all know EGFR mutation is the most common in the world. And in Asia also it constitutes about 40 to 50%. And India it constitutes nearly 50%. Our own hospital data is there. It is around seen in around 50 to 60%. Next common mutation is KRAS mutation. So the drug yet to approve, so sotatercept and other rare mutations all constitutes around 5 to 10%, we can say. That is exactly around 4.4%. So there are multiple methods to test the molecular methods we have discussed in the beginning only. So I will skip this slide. This is also scheme, and only one thing to discuss is we have now shifted from sequential testing to single platform or one-time testing. That is from sequential EGFR or separately testing to combinedly testing in a NGS method. So if we test EGFR all cross at a time and NTRK BRAF, then if it is positive, then target therapy. If it is negative, then PDL1 TMB testing, then immunotherapy or chemotherapy. So so there are many advantages. So now the standard of care is to test all the mutations at a time. So, and the test to be done in the upfront case, they are EGFR, KRAS, BRAF, ALK, Metaxon 14, RET, RAS1, NTRK. So because all these has target drugs, and definitely we have to do PDL1 testing depending upon the platforms. And the completion time that is around 10 to 14 days for the NGS. So coming to the benefits and challenges of NGS, we all know. So cost is the most important barrier against the barrier. Technical challenges, accessibility, potential false positive results, turnaround time which is usually 10 to 20 days, and one more thing is large deletions we cannot find in the NGS. And whereas coming to the benefits of NGS, we can test any mutation, unknown mutations also we can test, and good sensitivity, specificity, accurate identification of up to 3 times more clinically actionable alterations, and routine nationwide molecular profiling can be considered. Acceptable turnaround time. So coming to a new paradigm in NGS testing. So Novartis is providing patient assistance program or around, we can say, at a cheaper rate, the platform testing. So where they will test around 12 gene panel with PDL1 SP142 or PDL1 SP263. So this is for helping the patients to test the multiple genes at a time. Coming to the discussion of interest, so all positive constitutes around 7%. Like EGFR, it is seen in young women, non-smokers, and most of the times they present with the brain mets. So if you want to do MRI brain, so though it is suggested for all stage 3, stage 4, as we discussed, even stage 2 also. But if you want to do MRI to any specific mutation, then ALK is the mutation where they have high preponderance for the brain mets. Coming to the ASCENT-4 trial, which is a first-line ceritinib versus chemotherapy trial, which is a phase 3 trial. There they have compared ALK positive non-squamous cell adenocarcinoma lung compared with chemotherapy, standard chemotherapy versus 750 mg ceritinib, and their aim or primary objective is progression-free survival. So progressive-free survival, we can see the Kaplan-Meier curves, they have separated early and there is a wide gap. So we can see the PFS is doubled. This is about in the blinded independent review, and hazard ratio, that is 0.5. So 50% of the patients are benefited. P-value is quite significant, along with objective response rate, duration of response, and 24-month OS rate is around 70%. And the estimated risk reduction is around 45%. So, and there is a risk of progression or death is reduced by 34%. So there is both a PFS benefit and overall survival benefit also. Coming to the ASCENT-8, which is in Asian patients. So can we reduce the dose of ceritinib from 750 mg to 450 mg? That is from 5 tablets to 3 tablets with food. So this is a pharmacokinetic study, we can say, and the alteration with there is a interaction with the food interaction. So using that property, they have divided into 3 arms: 450 mg, 600 mg, 750 mg. So in 450 mg, though these are subgroup analysis, so 450 mg we can say equivalent to 750 mg, so that the number of pills will be reduced, so cost logistics will be less reduced, and the side effects will be reduced. So the 450 mg is equivalent to 750 mg. Coming to the brain mets, so upfront ALK positive patients will have nearly 30% of the ALK positive patients at upfront will have brain mets, and during their lifespan it increases up to 80%, so 70 to 8%. So at upfront 30% will have brain mets, 40% will have bone mets, 18% will have liver mets, and locally advanced it is around 5%. Coming to the during their lifespan, it increases up to 70 to 80%. So we want a TKI which has good penetration with the into the brain. So first generation TKI like crizotinib has less penetration, or it may or may not cross the blood-brain barrier. But the second generation TKI, that is alectinib, brigatinib, ceritinib, they have good brain penetration. Coming to the third generation, also they will also have the lorlatinib which can cross the blood-brain barrier. From the second generation, all the drugs will cross the blood-brain barrier. So ASCENT-4, it has shown PFS benefit both with brain mets and without brain mets. Though within the brain mets, the PFS is less, but it has shown benefit in both patients with brain mets and without brain mets. And they have shown intracranial rate also. So this because can avoid radiation therapy. Even patients with multiple brain mets who are asymptomatic, we can safely start, jump and start the radiation. So around 45% delta, that is difference is there in the intracranial response, that is around 72% in the ceritinib arm, whereas 27% in the chemotherapy arm. And within the CNS also, we can see around 9% had CR, 63% had PR, stable disease was seen in 13%, and progressive disease was seen in 4%. So within the brain mets also, we can safely avoid whole brain RT. So patients who are asymptomatic. So Asian patient subgroup analysis. So in all the settings, that is with brain mets, CR, PR, stable disease, ceritinib has scored more over the chemotherapy. So comparative efficacy. So though cross trial comparison is not exactly correct, so we can compare here ASCENT-4 with the ceritinib versus profile 1014 with crizotinib. Ceritinib was associated with significantly longer progression-free survival when compared to crizotinib. In the adjusted indirect comparison with external controls, second generation TK, that is ceritinib, was associated with significantly prolonged PFS compared to crizotinib. So here we can directly compare the curves, though this is not a correct way to compare because the patient characteristics are completely different. So here we can see profile PFS is 10.9 months or 7 months. In Ascent it is 16 months to 8 months. So there is a numerical and statistical difference. And here the overall survival also in profile. So if you see, we can compare, and the hazard ratios are better in the Ceritinib arm and non-estimable overall survival in the Ceritinib arm. Coming to the time to deterioration or quality of life. So Ceritinib is usually well tolerated drug. The only side effect is GI side effects. There can be diarrhea. So Ceritinib is significantly improved quality of life and significantly improved time to deterioration for lung cancer specific symptoms compared with chemotherapy. So these are the side effects, and most common side effects are GI side effects. Though we can see with all like TK, we can see hepatotoxicity can be there, skin toxicity can be there, but most common side effects are GI side effects. So clinical all TKs in first line. So there are all the generation drugs are approved. That is from the starting from the crizotinib first generation, profile 1014 trial, second generation Ascent 4 Ceritinib, and whereas in the Alectinib, Alex and JLX trial, Brigatinib Alta 1 trial, and coming to the Crown trial, Lorlatinib. So all the first generation, second generation, third generation, all the generations are approved in the first line. But how to decide? So we have to decide depending upon the patient characteristics, depending upon the age, comorbidities, site of metastasis, patient's preferences, patient logistics, and patient's preference in within the side effects also. And so this is the landscape. We all know what are the ALK inhibitors from the 2007. It is up to the 2022. So if you see NCCN broadly gives that all the generations are approved for first line. So if you see crizotinib, Ceritinib, Lorlatinib, Brigatinib, all are approved. So if you see cost-effective sequencing, Ceritinib, we can see it is a little cheaper drug. The PFS over Ceritinib first line PFS is around 26 months. Then we can start on Alectinib. Then we can give Lorlatinib. So this is one sequence. Suppose once we can start, the second thing is Lorlatinib. But the problems with Lorlatinib is, so what we have to start if the patient progresses. And other thing is Lorlatinib is highly toxic drug. So hyperlipidemias will be there, cognitive dysfunction can be there, peripheral neuropathy can be there. So if the patient is having brain mets, so what we have to give, the difference. So if the patient is having altered sensorium, whether it is because of Lorlatinib, whether it is because of brain mets, difficult to clinically diagnose. We have to do MRI. Then coming to the Alectinib and Lorlatinib, here comes though the benefit is there, but here comes the cost logistics. Coming to the Brigatinib, the problem is with the side effects, pneumonitis, ILD, life-threatening ILD can be there. So, and coming to the crizotinib, Alectinib, Lorlatinib, so crizotinib, but the benefit is less, and crizotinib, the brain penetration is very less. So what are the points to consider while starting ALK TKI? So this is not only for ALK TKI, this is for the all target drugs. So superior efficacy in first line. So we have to choose a drug which has good penetration, which is more efficient, and which has less side effects. So and which can treat the brain mets, which can even cure the brain mets. So like that TKI we have to choose, and it depends upon multiple factors, not a single factor. And sometimes we have to choose the TK which has rapid responses because the patient will have symptomatic disease. So at the time we have to use the TK which has rapid responses. And we have to think of second line because some patients will progress on first line. Sometimes we have to reserve for the second line depending upon the patient's characteristics. So we have to choose the ALK TKI depending upon the patient's characteristics. So there are no exact guidelines. So which TKI, because all the TKIs are approved in the first line. So coming to the conclusions of Ascent 4 trial, it has shown progression-free survival, OS data yet to mature, and progression-free survival even with brain mets, without brain mets, it is there. And gastrointestinal side effects most of the gastrointestinal side effects are mild, and they are the most common side effects. And efficacy and safety of Ceritinib was well established even in the Asian population because the 450 mg data is from the Asian population. And if many real world data or real world studies are also there that it tolerates very well. Thank you.
Thank you, Dr. Sanath. That was a wonderful presentation and you are on time. And next, I would request Dr. Monica Bopanna to speak on experience sharing on durvalumab in extensive stage small cell lung cancer. And this session is sponsored by Astra. Monica Bopanna, ma'am.
Yeah, I think you have to stop sharing the screen. I'm not able to share the screen.
Sanath, please stop sharing.
Yeah, 1 second. Yeah, you can see the slides, right? Are my slides visible?
Yes, ma'am. Perfect.
Yeah. So a very good evening, everyone. Thank you for giving me the opportunity to share my experience with the durvalumab in extensive stage small cell lung cancer patients. So I'll just begin with the case of a 35-year-old gentleman who presented in June 2020. He did not have any comorbidities and he was a smoker. His presenting complaints were a change in his voice that slowly progressed to aphonia or dysphonia. He was evaluated by an ENT surgeon and he was diagnosed to have vocal cord palsy. He underwent a CT scan of the brain, which was normal at that time. And he also underwent CT scan of the chest. In the CT chest that was done in August 2020, there was a small soft tissue lesion with the surrounding fibrosis in the left apical segment. And there were multiple enlarged conglomerated necrotic lymph nodes in the left hilar, paratracheal, and paraesophageal region, which was probably compressing the recurrent laryngeal nerve. And aortopulmonary window nodal mass was there that was compressing the left pulmonary artery. So based on the presence of this fibrotic lesion in the left apical segment, patient was started on ATT, thinking of tuberculosis as the primary etiology with mediastinal adenopathy. However, unfortunately, the condition of the patient worsened, and in September, within 1 month of starting ATT, he developed an episode of seizure. So he was first started on anti-epileptic drugs and an MRI brain was done. This showed a 2 into 1.9 into 1.7 centimeter lesion in the right temporal lobe with some surrounding edema, but not much mass effect. And there were multiple other subcentimetric lesions in the bilateral temporal, left frontoparietal and occipital regions. So a thoracic imaging was repeated that now showed an SOL in the left upper lobe that was now very big and it was extending into the mediastinum also. It was completely encasing the left pulmonary artery. Mediastinal adenopathy was there and there was consolidation of the left upper lobe. So if you see, this is the mass which is invading into the mediastinum. Lot of mediastinal adenopathy is also there. And the brain imaging showed brain metastasis, as I said earlier, the MRI brain. So a biopsy was done from the left upper lobe lung mass that came out to be small cell neuroendocrine carcinoma. PDL1 was done that showed a TPS score of 3 to 4%. So the final diagnosis of this patient is extensive stage SCLC with brain metastasis. So what is the next step? Whether to give brain radiation first, followed by systemic therapy. In the systemic therapy, whether to use chemotherapy or chemotherapy combined with IO are the questions that usually that come to our mind when we begin treatment in such a patient. So whether to treat the brain metastasis first or whether to start systemic therapy first, there's no consensus as such, but the important thing to remember is that patients who have symptomatic brain metastasis, definitely whole brain radiation has to be given first, followed by chemotherapy. That's the most common recommendation. Even NCCN also says that symptomatic patients, brain RT should be given before any systemic therapy. Unless there are indications for immediate systemic therapy, say, for example, if the patient is in SVCO, if the patient is very breathless, is having rapidly progressive respiratory compromise, then in such cases, we can give systemic therapy while continuing the medical decompression with steroids and mannitol and anti-epileptic drugs in order to prevent any cerebral event. And we can give off the first cycle of systemic therapy and then In the gap that's intervening, the 3 weeks gap which is there between the first and the second cycle, whole brain RT can be planned. So this is the usual way that we plan, and this is what even I practice, that in overtly symptomatic patients, if the thoracic disease is not very symptomatic, then I give whole brain RT. But if the thoracic disease is also very symptomatic and patient is also having seizures, then it's a very difficult scenario. But I think like we can start systemic therapy first, and then we can continue the steroids and anti-epileptic drugs, and then postpone the whole brain RT by about a few days to complete the first cycle of systemic therapy. In patients who are asymptomatic, we can administer systemic therapy. The whole induction of 4 cycles of systemic therapy can be completed, and then whole brain radiation can be planned. So this is what even NCCN recommends. Now, if you look at the chemotherapy regimens, before EP came to use, there were so many other regimens that were tried, drugs like cyclophosphamide, doxorubicin, vincristine, irinotecan, so many such drugs were used. But finally, now the standard of care for first-line, standard of care chemotherapy for first-line small cell lung cancer is etoposide platinum. That's either cisplatin or carboplatin. But if you see with any of these regimens, the median OS is very grim, ranging somewhere between 8 to 11 months, which is a very grim median overall survival. It's a very aggressive disease. We all know that. So this patient was first initially started just on chemotherapy with etoposide and cisplatin. And after the first cycle of chemotherapy, the patient was planned for radiation, whole brain RT, hippocampal sparing whole brain RT. 30 gray were administered in 10 fractions, followed by boost to the grossly visible lesions. Coming to the systemic therapy, what do the guidelines say? So from 2021 onwards, the addition of IO along with EP has come into use, and the preferred regimens category 1 recommendations are either carboplatin AUC 5 on day 1 and etoposide 100 mg per meter square day 1 to day 3 with atezolizumab at 1200 mg per meter, 1200 mg flat dose on day 1. That's given once in every 3 weeks for 4 cycles, and then that's followed by atezolizumab maintenance, 1200 mg every 3 weekly. Or carboplatin AUC 5 or 6 on day 1 with etoposide 80 to 100 mg per meter square day 1 to day 3, along with durvalumab 1500 mg once in every 3 weeks, again for 4 cycles, followed by durvalumab maintenance at 1500 mg once in every 28 days. So there's a difference here between the frequency of administration for atezolizumab and durvalumab. Atezolizumab is given 3 weekly, durvalumab is given 4 weekly. Cisplatin is also a platinum which can be used along with etoposide 75 to 80 mg per meter square on day 1, along with the same dose of etoposide, can be combined with durvalumab. So the reason why we have only carboplatin along with atezolizumab is because the trial of atezolizumab only used carboplatin, cisplatin was not used. Durvalumab is the only IO to be used in combination with either carboplatin or cisplatin along with etoposide. And that's why we have the option of giving either carboplatin or cisplatin. If patient is cisplatin fit, then cisplatin can be given. Now, whether to give consolidative thoracic RT in an extensive stage SCLC, it may be beneficial for selected patients. Definitely, it's not something that is offered for all patients. But if the extensive stage SCLC showed an excellent response, complete response, or very good response to systemic therapy, especially with some residual thoracic disease and a very low bulk extrathoracic metastatic disease, then in such patients, we can selectively offer thoracic RT for them. So the patient was actually started on chemoimmunotherapy from cycle 3 onwards. Durvalumab was added from cycle 3 and 1500 mg per cycle was given, followed by 1500 mg as maintenance once in a month. What is the role of immunotherapy in small cell lung cancer? Why it is so, why it's coming into use so much is because we know that SCLC is a very chemosensitive tumor, and chemotherapy-induced tumor cell killing causes more tumor antigen release and exposure of the immune system, thereby causing more tumor infiltration with lymphocytes. PD-1, PD-L1 interaction is very, very avid in small cell lung cancer, and therefore, when there is PD-1 or PD-L1 inhibition, that restores tumor-specific T-cell immunity, and there is reversal of the immune suppression that leads to deeper and more durable systemic anti-tumor response. So, and we know that the tumor mutation burden is also quite high in small cell lung cancer. So a lot of new antigens are there. And that also makes a very fertile ground for good action by IOs. Let us look at the Caspian trial. This included newly diagnosed extensive stage SCLC patients. About 800 patients were randomized. The patients had to be of ECOG performance status 0 or 1 with a life expectancy of 12 weeks or more. They should have at least one target lesion so that response can be assessed by RECIST 1.1. Stratification was done according to whether the patients received cisplatin or carboplatin. In the experimental arm, patients received EP, investigator's choice of cisplatin or carboplatin, along with Imfinzi. 4 cycles were administered once in every 3 weeks. About 268 patients were on this arm. And after the completion of these 4 cycles of chemotherapy, durvalumab was continued once in every 4 weeks until progression. That was the maintenance phase. And in the other arm, there was just EP with investigator's choice of cisplatin or carboplatin. Up to 4 to 6 cycles of chemotherapy were used. And this was also given 3 weekly. 269 patients were there. The third arm, it's not very important. We're not discussing about this, but basically durvalumab EP along with an investigational agent was used in the third arm. The primary endpoint of Caspian was overall survival. There were multiple key secondary endpoints, and they were progression-free survival, overall response rate, OS at 18 months, PFS at 6 months and 12 months, and health-related quality of life. The important things to note here are that Caspian allowed for investigators' choice of platinum, which is what we do in the real-world setting. We first assess for fitness for cisplatin. If they're cisplatin fit, we go ahead with cisplatin. If they're not fit for cisplatin, then we use carboplatin. So therefore, Caspian reflects more of what we do in the real-world scenario. Patients with asymptomatic or treated brain metastasis could be included. The control arm allowed for up to 6 cycles of EP chemotherapy, and the prophylactic cranial irradiation was as per investigators' discretion, as per the treating clinician's discretion. The study design that was different, like the study design differentiators between Caspian and IMPAR 133 were that there was no biomarker selection in both of them. All comers were included. Untreated brain metastases were excluded from IMPAR 133, whereas they were included in Caspian. Prophylactic cranial irradiation was allowed in the control arm in both the trials, and about 10% of the patients on IMPAR 133 received that. Prophylactic cranial irradiation allowed in the experimental arm, that was not allowed in Caspian, whereas it was included in IMPAR 133. Up to 6 cycles of chemotherapy in the control arm was not allowed. It was only 4 cycles, even in the control arm in IMPAR 133, whereas in Caspian, up to 6 cycles of EP could be given. Cisplatin was not given in IMPAR 133. It was used in Caspian, and carboplatin was used in both. So Caspian study inclusion criteria is reflective of real-world clinical practice, where we have to deal with patients with brain metastasis, without brain metastasis, patients who are eligible for cisplatin, who are not eligible for cisplatin. And also it was compared against up to 6 cycles of chemotherapy with optional prophylactic cranial radiation, which is another very important factor. So salient aspects of Caspian trial design are durvalumab 1500 mg with platinum etoposide 3 weekly for 4 cycles in the initial treatment phase, followed by a durvalumab maintenance of 1500 mg once in 4 weeks until progression as maintenance. Choice of platinum, cisplatin versus carboplatin. OS was the final primary endpoint. Control arm could receive up to 6 cycles of chemotherapy. Optional PCI was offered only in the control arm in the maintenance phase, and it was not given during the durvalumab maintenance. Asymptomatic as well as treated and stable brain metastasis patients were included. The overall survival based on baseline brain metastasis, it was on the overall survival analysis, it was seen that durvalumab with EP consistently improved OS as compared to EP alone in patients, regardless of the presence or absence of brain metastasis. So if you see, this is the OS curves in patients with brain metastasis, median OS of 12 versus 8.8, which was statistically significant, a hazard ratio of 0.69. And even in patients without brain metastasis, the median OS was 13 versus 10.5 months with a hazard ratio of 0.74, which was again statistically significant. Progression-free survival, at 12 months, it was 17.9% versus 5.3%. At 18 months, 13.9% versus 3.4%. And at 24 months, it's important to note that 11% of the patients, that's more than 10% of the patients on the durvalumab arm were still progression-free as against 2.9%. So hazard ratio for PFS was 0.8, median PFS of 5.1 and versus 5.4 months. So more than 3 times the number of patients were progression-free at 12 months and nearly 4 times the number of patients were progression-free at 24 months with durvalumab and EP as compared to EP alone. 9.1% of the patients have been on durvalumab for 3 years or more, and about 10% of the patients were continuing treatment with durvalumab at a 3-year data cutoff. The overall survival in the entire population, that was the primary endpoint, and the median OS was 12.9 months on the durvalumab arm versus 10.5 months, which was statistically significant with a hazard ratio of 0.71. 3 times more patients were alive on the durvalumab EP arm as compared to EP alone, 17.6% versus 5.8%. So more than 3 times the number of patients were alive on the durvalumab arm at the 36-month data cutoff, that is at the 3-year data cutoff. So Imfinzi with EP improved the estimated percentage of patients alive, with 3 times more patients being alive at 3 years as compared to EP alone. There's a clear separation of curves, which is sustained. And important thing is that there's a notable flattening of the curve that was observed from 27 months onwards. There was a notable flattening of the curve. And that means this small percentage of patients who had a sustained, who were still alive, even at 3 years, it supports a sustained long-term OS benefit that IOs can give, that durvalumab arm that we have seen in the durvalumab arm in the Caspian study. So that about 15 to 20% of the responders have a very prolonged PFS and prolonged OS. They are the ones who really respond very, very well to the addition of IO, who benefit the most from the addition of IO to chemotherapy. If you look at the subgroup analysis, irrespective of the subgroup, irrespective of the performance status, 0 versus 1, smoking, whether brain metastases are present or not present, irrespective of the race and the region, there was a consistent benefit towards the durvalumab that was in favor of durvalumab. So durvalumab and EP was evaluated in key patient subgroups reflective of clinical practice in ES, extensive stage small cell lung cancer. So cisplatin and carboplatin eligible patients were taken. Patients were over 65 years, former as well as active smokers, and patients with brain and CNS metastasis with and without. All of these patients were included, and irrespective of the subgroup, there was a consistent benefit. Confirmed objective response rates, 67.9% versus 57.6%. So there's a superior objective response rate with durvalumab. And the duration of response, if you see, the median duration of response was almost the same. But if you see at about 1 year time point, the patients who were continuing to respond were more in the durvalumab arm, 22.7% versus 6.3%. So this is the first approved IO, Imfinzi, to improve both response rates, that's 68% versus 58%, and durability of response at 24 months. So at 24 months also, if you see, there were still a significant proportion of patients who were continuing to have the response, 13.5% versus 3.9%, who were still continuing to respond. So the duration of response was also very good on the Imfinzi arm. So more than 3 times the patients were remaining in response at 24 months with durvalumab and EP as compared to EP alone. This patient on follow-up PET scan, it was done in January 2021. By then, patient had received radiation, 3 cycles of chemotherapy and 3 cycles of immunotherapy were given. And the follow-up PET scan showed a significant resolution, if you see, compared to the previous PET that I had shown at baseline, there was a significant resolution of the mass as well as the brain lesions have responded well. So there was a decrease in the right parieto-occipital lesion. There was a decrease in metabolically inactive minimal soft. This was another follow-up scan, which was done 3 months later, and it showed metabolically inactive, minimal soft tissue thickening in the AP window, and that was seen encasing the pulmonary artery, and there was no metabolically active disease. So basically, the patient was in a complete response. So I have treated 3 patients so far with this combination, durvalumab with EP. All had extensive stage small cell lung cancer. 1 out of these 3 patients had brain metastasis, symptomatic brain metastasis at presentation. And it is this patient who had progressive disease after 4 cycles of EP and durvalumab. However, we used suboptimal dose of durvalumab in this patient. We could use only 1000 mg per cycle because the patient was being sponsored by a government body, and he had a capping limit on the cost of therapy, so we couldn't give the full dose in him. He progressed after 4 cycles of EP and succumbed to the disease a few weeks later. The second patient had a partial response to 4 cycles of EP and durvalumab, and he had a progressive disease after the 3rd maintenance dose of durvalumab. 1 patient had a near CR with 4 cycles of EP and durvalumab, and then he received 2 maintenance doses of durvalumab so far, and he's been doing so very well so far. And all of the patients I'd used carboplatin because they were not fit for cisplatin. So Imfinzi is the only IO with clinical trial data supporting a 4-weekly maintenance dose administration schedule for extensive stage SCLC patients. Another important thing is the life years and the quality adjusted life years were also, although this cross trial comparison is not very correct, but just to see like as a hypothesis generating or just like a food for thought, if you look at only EP versus the life years and the quality adjusted life years in the IMPAR trial, and if you look at what we are seeing in the Caspian trial, definitely the durvalumab with EP adds 1.14 life years and 0.84 quality adjusted life years as compared to treatment with EP alone. And so even the quality of life is also better. So to conclude, durvalumab with EP is the new standard of care in the first-line treatment of extensive stage SCLC. It has shown sustained improvement in OS compared with the robust control arm that is reflective of a real-world scenario by allowing up to 6 cycles of EP and the use of prophylactic cranial irradiation as compared to the results from the atezolizumab and carboplatin etoposide study of IMPAR 133. Durvalumab is the only IO that provides flexibility of choosing cisplatin or carboplatin along with etoposide. Benefit with durvalumab with EP was observed across all the subgroups, including the patients who had brain metastasis. More than 17% of the patients on durvalumab and EP arm are surviving even after 3 years, showing a prolonged survival benefit. Imfinzi with EP provided a high response rate and demonstrated ongoing responses even at 2 years in 3 times more patients as compared to EP alone. Durvalumab offers convenient once-monthly dosing regimen in the maintenance phase. Safety findings remains consistent with the known safety profile of durvalumab and EP. And of course, IOs are still beyond the reach of many eligible small cell lung cancer patients who are potentially eligible. Maybe we should do more lower dose trials because low dose immunotherapy is the upcoming concept now. It is being tried in many patients, and recently we have data from in head and neck cancer patients also with low dose nivolumab. So maybe in the future, low dose trials where only 500 mg can be used and it can be seen whether the efficacy remains the same is something maybe for the future. And probably the companies also have to come up with better patient assistance programs which will be more feasible for the patients. Thank you very much for your patient listening.
Thank you, Dr. Monica. It was wonderful talk. And you have really told about real practical aspects out of 2 immunotherapy agents, which one to choose and what are all the differences, and how Caspian trial is in sync with real world practice. And I hope Astra guys have taken up your suggestions. Maybe probably in future they might come up with more PAP if feasible. And it was a wonderful session. I would thank all the speakers and panelists for the session, and all the academic partners for the today's CME. I would like to thank Intas, Astra, Cipla, Roche, and Hetero Healthcare for granting the academic grants. Thank you, one and all. And if you have got no questions, we would be happy to close the session.
Thank you, sir. Thank you.
Thank you.
Thank you,
Thank
every
you.
doctor.
Thank you, everyone, for joining. Thank you, Rajesh Bhulam, sir, and good night, everyone.